السلام عليكم.
عليكم السلام.
How are you guys?
Very fine, thank you.
Okay, today inshallah we'll start the first mock exam. Some stations are history, stations are procedures, resuscitation. We are making some station from each category. We have for practice today Sheikha, Abbas, Michael, Atol, and Santos. Please, if anyone interested to practice, you can raise your hand. We'll start by Sheikha.
Yes, doctor. Assalamualaikum.
Alaikum assalam. So you will find first station. It could be any category. You have 30 seconds, then 60 minutes, okay?
Okay. Okay, I'll start.
Start 30 seconds.
Okay. Okay, I'll start.
Yes.
Okay. Good afternoon. I'm Dr. Sheikha ED Registrar. May I know your name and level, please? Nice to meet you. So we have a patient coming with a breathing problem. Can you please prepare the airway and circulation kits? Can we take handover from the ambulance crew?
This patient collapsed at home and is drowsy now.
Okay. So I'll start by assessing. Is the patient conscious?
Drowsy.
Okay, and is the airway patent?
Drowsy.
Okay, so we're gonna please clear the airway and put OPA and put high flow oxygen. Okay, we're gonna move to breathing. How's the SpO2, RR, neck veins, trachea, inspection, palpation, and auscultation of the heart and lungs?
The SpO2 is 80, RR is 60, and trachea central, neck veins normal, inspection, respiratory distress, palpation, normal expansion, and percussion resonant, auscultation, bilateral basal crepitation, and heart sounds tachy but normal.
Okay, so we have a patient who is hypoxic, tachypneic, with bibasal crepitation, since the neck veins are normal with no added sounds, and trachea central. So this most likely it's an infection of the lung, since the neck veins are not congested, unlikely to be from the heart. So okay, so we're gonna call please the ICU team and. We put the patient on high flow oxygen. Okay, I'll move to circulation. How's the blood pressure, heart rate, CRT, and peripheral pulses?
Blood pressure is not recordable.
Okay, can we look and listen feel for signs of life?
Yes, has signs of life.
Oh, okay, so we have a patient who is hypotensive with poor perfusion. So most likely we're dealing with a patient with the septic shock due to the chest infection. So we called already the ICU. Let's check if they arrived. And let's give the patient, we'll start the patient fluids. bolus, 30 ml per kg. First, we're going to start with 500 with a total of 30 ml per kg. And we're going to give the patient a broad spectrum antibiotic. And we're going to activate, we're going to put two IV access, extract blood for septic workup, blood culture, infectious screen, toxicology and hematology, biochemistry, and we're going to do the sepsis 6 bundle. Okay, we're going to move then to we're going to move to the then we're going to move how's the patient GCS, blood sugar, any signs of lateralization, and how's the pupils.
GSS is 9 and pupils equireactive. Blood sugar is 5. No signs of lateralization.
Okay, so I'm good with disability. So how's for the exposure, any signs, any other abnormalities, and how's the temperature?
Temperature 39.5.
Okay, so the patient has fever, which goes also with our impression of septic shock due to the chest infection. And we're going to also insert the Foley's, part of this sepsis bundle, and I'm gonna hand over to the ICU team. I have a patient with septic shock due to a chest infection. He would need admission in the ICU. So I'm going to move to reassessment of the patient. Is he still conscious?
The patient is drowsy.
Okay, and is the airway patent? Okay, and I'm going to move to how's the patient, the RR and the SpO2.
SpO2 is not reading.
Can we look, listen, feel for signs of life?
Has signs of life.
Okay, do we have the chest X-ray and ABG or still?
Blood gases available now.
Okay, what's the pH, bicarb, the CO2 and potassium, sodium, and base excess?
pH 6.9 and BO2 is 5 and the BaCO2 is 9 and the bicarb is 10. Lactate
Okay.
is 5.
Okay, so we have the ABG is showing signs of type 2 respiratory failure with high lactate due to the sepsis. So we will need to call the anesthesia and check if the ICU team arrived also, and we will prepare for intubation of the patient. We're going to do RSI, and we intubated the patient, so we're going to check for bilateral chest rise. We're going to check for auscultation and end-tidal CO2 and improvement in the SpO2.
Improving, but the patient is not responding now.
Look, listen, feel for signs of life.
No signs of life.
Okay, can we activate the cardiac arrest call? And we're going to start, please start high quality CPR and connect the patient with the pads and the cardiac monitor, and let me know if we have a rhythm and continue CPR, please. Do we have a rhythm? Okay, so we can see there's an organized rhythm and check there's no pulse, so we have PEA. So we're going to continue the high quality CPR, and we already extracted the blood, and we're going to give the first dose of adrenaline, 1 milligram, and we're going to check for the reversible causes. So most likely this patient, because of the septic shock and due to the chest infection, we gave the antibiotics, and we already intubated the patient, and we're gonna continue back valve mask every 30 to 2, and we're gonna VBG. There's no electrolyte imbalance, correct? Is that correct? Okay, and we gave the patient fluid also. Okay, so 2 minutes passed. How can we stop and check the rhythm? Okay, we still have the PA. Let's continue high quality CPR.
Okay, thank you. Thank you, doctor.
Okay.
Okay, excellent and perfect. But when the patient has cardiac arrest, you have mistakes.
Mm.
You are doing very well, perfect before cardiac arrest. But once the patient has cardiac arrest, you have some mistakes. Um, I will comment on the cardiac arrest first. Patient has BA, excellent. You started adrenaline, okay. You can say the most likely problem of cardiac arrest is H
Okay.
or T, right?
Yeah.
Do you have S?
No,
Why you say
we don't.
sepsis?
Yeah,
You
I
have
don't know.
4H and 4T. Do you have S? You have 4S?
No, we don't.
No. So you should say like that. The most likely problem is choose from H and T's only. Clear?
Okay.
So hypoxia, hypovolemia because of sepsis. Easy?
Yeah, easy.
For example, patient has chest pain. You will say because of C, chest pain?
No,
No. Okay. You can say T, thrombosis. H, hypoxia because of
sepsis.
no, I'm talking about, for
Oh,
example, patient chest pain. So
oh yeah,
you will
because
say
of.
T thrombosis and H hypoxia. Clear?
Okay. Yes, clear.
Because of MI, like that.
Yeah.
So this patient has sepsis. Yes, of course, but you should say the most likely problem is H hypoxia, H hypovolemia because of sepsis. Should be like that. Okay.
Yes.
Okay. What else? You said 2 minutes passed. I will check the rhythm. You did not ask about signs of life.
Mm.
You assumed the patient is still in cardiac arrest. Okay. And this is fatal mistake. So if you are assuming the patient in cardiac arrest, you are not checking signs of life or not checking the central pulse, you will give adrenaline again. What if the patient has ROSC? Adrenaline with ROSC, the patient will die.
Yes.
Adrenaline with the patient has ROSC, the patient will die. Clear?
Clear.
Adrenaline in cardiac arrest will make ROSC, but adrenaline with ROSC will go to death. Clear? If you give adrenaline to someone is alive, he will die, right?
Yes.
Because you are giving bolus. Okay, bolus to someone has ROSC, dangerous. So you should not assume signs of life. You said 2 minutes passed. I will check the rhythm and the signs of life. Ask it clearly. Any signs of life? Clear, doctor?
Yes, clear.
Okay. You are doing well. The patient already intubated before cardiac arrest. So you said 30 to 2. No, it will be continuous compression and ventilation, one ventilation every 60 seconds. Clear?
Yes.
So if the patient has cardiac arrest without intubation, 30 to 2. With intubation, continuous compressions and ventilation every 60 seconds in adult, every 3 seconds in pediatric. I wish it's clear.
Yeah, it's clear.
Otherwise, you are perfect. You are very organized. You are very fluent. You have good leadership skills. You have resuscitation skills. You are safe, doctor, but in cardiac arrest, not safe. Clear? So I
Clear.
will give you 8 out of 10. If you are doing in cardiac arrest well, I will give you 10 out of 10. Thank you.
Thank you.
Well done. In breathing, you ask about blood gases and the X-ray. Excellent. You are doing well. In second C, if the patient is not in cardiac arrest, you can ask about blood results and ECG also. Well done. Okay, next one, Abbas.
Yes, sir.
Yes. So the next station, you have 30 seconds and 6 minutes.
Hello, my name is Dr. Mohammad Abbas Khan. I am the ED registrar here. May I confirm your name and age, please?
I'm John. I'm 45 years.
Okay, nice to meet you, John. How can I help you today?
I have chest pain, doctor.
Okay, I have been told to take some data from you. Is it okay with you? Okay, very sorry to hear about that. Are you comfortable? Do you need any painkillers?
The nurse gave me morphine.
Okay, can you tell me more about it?
Yeah, the chest pain started 1 hour ago, on and off, severe, and started sudden in the center of my chest.
Okay, you said that it is sudden, severe, and in the center of the chest, and it is on and off. It is for the last 2 hours. Is it okay?
1 hour.
Okay, 1 hour. Okay, can you tell me, is it affecting your daily life?
Once started, I cannot do anything.
Okay, can you describe the pain? Is it gripping? Is it stabbing? Is it just like tearing pain?
Stabbing, sharp,
Okay, is this pain related to any other area, for example, jaw or your left hand?
right arm.
Okay, right eye. Okay, anything cause or worsen it?
No,
Okay, any previous such attack in the past?
no.
Okay, on the score of 1 to 10, how much will you score?
9,
Okay, 9. Okay, can you tell me, is there any heart racing?
no,
O- Okay, any shortness of breath?
no,
Any loss of consciousness? Any headache?
no,
Any blurring of vision?
no,
Okay, is there any abdominal pain along with it?
no,
Any change in bowel habits?
no,
Any change in urinary habits?
no,
Okay. Any limb weakness? Any numbness?
no,
Any fever? Any history of trauma?
no,
Okay. Any loss of weight or any constitutional symptoms?
no,
Okay. Any lumps and bumps?
no,
Okay. Do you have any past medical disease?
no,
Okay. Any previous surgery?
no,
Any prescribed medications?
no,
Any allergy to medicine or anything?
no,
Any disease runs in your family?
no.
Okay, where do you live and with whom do you live?
I'm living with my family downtown.
Okay, do you smoke, drink alcohol, or by any chance take any illicit drugs?
No,
What do you do for a living?
I'm carpenter.
Okay, what are your do you want to add anything?
No.
Okay, what are your concerns?
Is it heart attack, doctor?
I appreciate your concerns, but the data we have taken from you, you have the age is young and this chest pain is severe. But the good news is that your age is young, so it could be heart attack. But we will do complete physical examination. We will shift you to the observation room and have complete physical examination from head to toe, and also we will examine your chest, heart, and lungs, and also we will do some blood test, including the blood test, inflammatory markers, infection screens, and also cardiac enzymes, heart enzymes, heart function test. And if we find, according to the heart score, if we find any problem in ECG, and we will deal accordingly. And if we can find here is an ECG, and we can see that there is a sinus rhythm and the ST. We cannot see any ST elevation or any depression. So the good news is that we can rule out this, but we have to look for the cardiac enzymes and wait for that. So if we do not find anything, then we will discharge you the printed leaflet discharge slip to your GP. But if we find any raise in the troponin levels, then we will refer you to the cardiologist, and he will deal you
So
accordingly.
is it
Is it
heart
okay?
attack, doctor?
No, fortunately, we have seen that the ECG is normal. So up till now, it is not heart attack, but we'll have to wait for the cardiac enzymes. So this is a good news.
So is this chest pain heart attack or muscle pain?
It can be muscle pain. Yes, your concern is right. But from the ECG and her
So I will go
history,
home.
yes, we will discharge you the printed leaflet discharge slip to your GP with follow-up.
Okay, thank you. Your time done. What do you think, Abbas?
Sir, actually, I was expecting that.
I misled you.
Yes.
I wish you will not find the actor like me.
Okay.
Okay. So you are doing perfect. But heart attack or not from the history, not from the ECG. Clear?
Yes, yes, sir, yes.
Th- This this chest pain in the center or not in the center?
Yes, it is in the center, sir. Yes.
Heart attack. On and off or
Yes.
continuous?
It was on and off, sir.
Heart attack. The pain is severe or mild?
It was severe, sir.
Heart attack. The pain is referred or not?
Yes, it was
Heart
referring, sir.
attack. The pain is 1 hour or few days
Sir, 1 hour,
or few
sir.
weeks.
1 hour.
So heart attack. Clear?
Yes, yes, sir.
Any pain with this character, heart attack until proven otherwise. Easy?
Yes, sir, yes.
Okay. According to heart score, the H2, the ECG, I'm talking in general, not in this patient. The H
Okay,
represent
sir.
2 points, the ECG represent 2 points, A age represent 2 points, and R risk factor past medical disease represent 2 points, and the T troponin represent 2 points, right?
Yes, sir.
In this patient, H typical or not typical?
Typical, sir.
Heart attack, right?
Yes, sir, yes.
H heart attack, it means typical, it means 2 points. Easy?
Yes, sir. Yes,
And
sir.
then we have ECG. ECG here normal or abnormal or significant ST depression?
Normal, sir.
Normal, 0 point.
Yes, sir.
Okay. So normal ECG relevant to the E, not relevant to the H.
Yes, sir.
So H heart attack. H is typical. If the H is typical, it means 2 points. If the H is not typical, 0 point. If the H is not clear, the patient has pain in the center, for example, the pain on and off, but not referred, not blah blah, not blah blah blah. It means not typical and not typical. Clear?
Yes. Yes, sir.
Okay. It means in the middle, it will give 1 point. So in this patient, 2 points for each for history.
Yes. Yes,
Okay.
sir. Yes.
Regarding ECG, if the ECG is showing significant ST depression, 2 points. If the ECG is normal, 0 point. If the ECG is non-specific T-wave inversion, like blah blah blah, it will be 1 point. Okay, so this one
Yes.
is clear, 0 point, right? Okay.
Yes, sir.
Regarding the age, if the age is more than 65, 2 points. If more than 45, it will be 1 point. Here, 45, borderline.
Mm.
You can consider 1 point, right?
Yes, sir. Yes.
Okay, so we have the age 2 points and the age 1 point. It means 3 points until now, right?
Yes, sir.
Risk factors, any past medical disease?
No,
No.
sir.
Any risk factor apart from past medical disease, like smoking, anything else? No. So 0 points. Okay,
Yes,
so
sir.
3 points until now. And regarding heart, HEART, troponin, we don't have troponin. So the patient score 3 points. If the score is less than 7, you will admit for observation. If the score more than 7, you will do STEMI alert and the BCI. Clear?
Yes, sir. Yes.
Okay. This patient, you will discharge or you will admit?
Admit, sir, very quickly.
Admit. If the H
Yes.
is typical, you should admit, whatever for observation or for BCI. Easy?
Yes, sir. Yes.
I wish it's clear now.
Yes, sir. Yes.
For the exam and for the ER department, real practice, okay? Okay.
Yes, yes.
So any H, 2, any H in heart score 2, don't discharge the patient. If the H is 0, if you want to discharge the patient, discharge. Clear?
Yes, sir.
Okay. So you will give the patient aspirin Plavix also? Yes. The score is 3?
Yes.
Yes. Because the H is typical.
Yes, sir.
Even troponin uh, not yet available? Yes. Even normal ECG? Yes. Clear? Because maybe it's a
Yes.
non-STEMI.
Yes, sir.
If the chest pain is typical and the troponin is positive, it means serious. Clear? Okay.
Yes.
So he said, is it heart attack? I'm sorry, it could be heart attack. Easy?
Mm. Yes, sir.
Because the pain in the center, give him idea. The pain in the center and on and off 1 hour ago, severe, referred to your arm, and blah blah. Easy?
Yes, sir.
Okay. So you will give him aspirin 300 and Plavix 300 oral, morphine given already, you can titrate again, and nitroglycerin if no contraindication. And you will do consultation with heart doctor. So you can tell him, we will wait. You are under observation now, under cardiac monitor, heart monitor, and if the heart enzymes or heart functions are abnormal, we will do invasive procedure, which is called BCI. Okay. If heart enzymes normal, we will admit you under observation to repeat the heart functions after 3 hours. I wish it's clear.
Yes, sir. Yes.
I will give you 8 marks. Okay.
Thank you. Thank you, sir.
If you call the heart doctor, even if you will not do well with the patient, you still safe doctor. But if you will discharge the patient, it means you're unsafe doctor. So
Yes.
if you are not sure, don't say discharge.
Okay, sir.
Okay. So again,
Thank you.
you will call the heart doctor. Even in real practice, if you call the heart doctor and if the patient is for discharge, no problem. If you will call the heart doctor and he will come and he will be disappointed because you are calling him for muscle pain, better than discharge the patient with MI. Clear?
Yes.
Okay. So take care. But
Thank you. Thank
regarding the accuracy, well done. Almost
you.
100%. You did not miss any point. Skillfulness, you are very fluent. Efficiency structure, you are very organized. Supportiveness, you are caring about pain, you are caring about everything, giving information in pieces, questions in pieces, pausing, safety. Uh, you are not safe in the point of discharge. Okay? Okay.
Yes.
Well
Yes.
done. Thank you. Next one,
Thank you.
Michael.
Yeah. Hi,
Michael?
Patani. Hi. Hi, I can hear you.
Yes. How are you?
I'm fine, thank you. How are you?
Yes, fine. The next station, you have 30 seconds and 6 minutes.
I'm ready now. Hello.
Yes.
My name is Dr. Koyi. I'm one of the ED registrars. What's your name and what's your grade? Are you ALS trained? Okay, we're expecting a 51-year-old male with a severe chest pain. If we can get the airway and circulation equipment ready, and as soon as the patient arrives, we'll get straight into it, okay? Have we got any extra hands? I'll need one extra nurse to take
Patient
care of the
arrived.
circulation. Okay, any handover from the ambulance crew?
Yes, the patient has severe chest pain and the patient is shouting.
Okay, I'll just ask the nurse to prepare some morphine for this patient while I go ahead to assess the patient. And so the patient is shouting, so the airway is patent.
This is the ECG we did in the ambulance car, doctor.
Okay, that's all right. Can I ask? I'll just ask one of the nurses to just activate the PCI lab and then just get the STEMI team on board while I go ahead to assess the patient. So again, the airway is patent. The patient is shouting. I'll just give the patient 15 liters of oxygen via non-rebreather mask. I'll go ahead to assess the B now. So I'll expose the patient's chest and I'll look at the neck. Is there any distended veins? What's the situation of the trachea? What's the respiratory rates? What's the saturations? And then inspecting the chest, palpating, percussing, and auscultating the chest. Any findings?
The SpO2 is 9.6 and RR is 40. The neck veins are normal, central trachea, inspection, respiratory distress, and normal patient, normal expansion, resonant, and normal heart sounds and normal air entry.
Okay, so from the information I have so far, it appears the patient is in respiratory distress and the patient is tachypneic at 40. The rest of the parameters are fine. At the moment, the patient is on oxygen. We'll just go ahead to assess C now. So far, we've got the CCG. Can you connect the patient to a cardiac monitor, please? And then put the blood pressure cuff on. So can I get a blood pressure at the moment on this patient? I'd like to get the CRT. Then I'd like to palpate the peripheral pulses.
Blood pressure is normal, CRT normal, and
Okay. It looks like the room has changed. So I'll look, listen, and feel. Are there any signs of life?
yeah, I told you the blood pressure is normal.
Right. Okay. It looks like the patient is the ventricular tachycardia now. So we need to, and the patient has got ischemic chest pain. Please, can we connect the pads to this patient? We need to cardiovert this patient because I can see the rhythm has changed to a VT and he's got an unstable feature, ischemic chest pain. So we connect the pads now. Can we get the anesthetic team on board to give this patient some conscious sedation for this procedure? Okay. So I'll assume that is done now. So I want to cardiovert this patient. I would shock this patient at, I'll start with 150 joules of cardioversion for this patient. And then after that, I'll reassess the patient. Has the patient still got any signs of life at the moment after cardioversion?
Yes.
Okay. So I'm still having a look at the patient. It looks like the VT is not changed. So we need to prepare to shock this patient again. And the patient has still got ischemic chest pain. Is that correct? Okay, so let's cardiovert this patient at 150 joules again, if that's all right. So that is done and shock delivered under conscious sedation. So I'll reassess the patient. Okay, it looks like the rhythm is still not changed, and we've still got the patient in ischemic chest pain. In the meantime, can we give this patient a dual antiplatelet therapy? So we give 300 milligrams of aspirin and ticagrelor, if that's all right. So I'll cardiovert this patient again at 150 joules. Okay, so that's still not changed. So we've cardiverted this patient 3 times, and the rhythm hasn't changed. And we've got a patient with ischemic chest pain, and we've activated the PCI lab so far. So what I'll do next is to commence this patient on chemical cardioversion with amiodarone. So I want to give this patient 300 milligrams of amiodarone over 30 minutes. And so while that is going on, I'll just go ahead to continue assessing the patient. So I'll just move to D now. And what's the GCS of this patient?
Sedated.
Okay. And so we've got our amiodarone going. And what's the blood glucose?
Blood glucose 5.
And what are the pupils doing?
Normal.
And then what any signs of authorization?
Normal.
Okay. And then going ahead to E now, I will expose the patient. Anything to find on exposure, including checking the temperature. Any findings at all?
Normal.
Okay, that's all right. So we've got a patient that came in with ischemic sounding chest pain, initially sinus rhythm that moved into ventricular tachycardia with unstable features. We've given 3 shocks, and we have
Patient has
started.
no signs of life.
Right, so no signs of life at the moment. So we've got a cardiac arrest patient now. Can we put out a cardiac arrest call, and then commence chest compressions immediately? Connect the back valve mask and connect. We've got the pads on already. So start giving high quality chest compressions, the rate of 30 to 2. As soon as the pads are on, can we stop chest compressions? So we've still got a VT. So we need to deliver unsynchronized shocks now to this patient. Okay. So we need to get ready. We need to charge at 200 joules unsynchronized. So off the chest now, a shock delivered. Okay, so continue chest okay, looks like we've got an organized reading now. Look, listen, and feel. Has the patient got any signs of life, any pulse?
Yes.
Okay, so the patient has got pulse. So we've achieved ROS now. Thank you, team. So let's just reassess this patient. At this point, we need to get the cardiologist on board. And again, we need to call the cath lab again because this patient needs to be urgently perfused. It looks
Okay,
like.
thank you. Thank you. Your time done. Okay. What do you think, Michael?
I don't know. I think I probably missed some steps.
Okay, I think you did well. In the start, when you take handover from the ambulance crew, so they offered this ECG, right?
Yes.
Obvious STEMI, right?
Yes.
I don't care what is the type of STEMI, whatever, anterior, posterior, inferior, lateral. So this patient needs a BCI. You did not, you did not mention STEMI alert. You did not mention activate cath lab.
I mentioned that, Dr. Annie.
No, I mean when you saw the ECG immediately before airway.
Okay.
I show you this ECG before touching the airway, right?
Yes.
So once you see the ECG, it's obvious STEMI. Is this ECG wrong? Is this ECG wrong?
It's the correct ECG. That was presented.
Do you think the ambulance crew did by mistake?
No.
This is wrong ECG, wrong leads? No. You have ST elevation in anterior leads and reciprocally changes in inferior leads, right?
Yes.
So for sure it's a STEMI. Do you have any uh, suspicion of wrong ECG procedure? No. So call. So number one, you can say the ECG is showing STEMI, massive STEMI. It's obvious. If more than two small square in chest leads, but this one more than six small squares, it means massive, right?
Yes.
Number one, STEMI alert. Activate cath lab. Give the patient is conscious shouting, right? Give the
Yes.
patient 300. You will give in A, but you give aspirin and Plavix. You did not mention aspirin and Plavix by name. You should mention them by name. You should give them in A airway if the patient is conscious. But you give them when you did sedation for the patient. Is it logic to give him after sedation? He cannot swallow, right?
Yes.
Not logic. So you should start STEMI alert, start cath lab in A. I'm not talking about A in general, no, A in such a patient because the ECG shown in A. This is the point. You should give aspirin and Plavix in airway once you discover it's STEMI. If the ECG not shown in airway, delay until you catch the ECG. Did you get my point?
Yes.
Okay. Here also you did conscious sedation. Excellent. So call anesthetist. You give three DC shocks. Okay, excellent. You give amiodarone. Okay, the patient was not um, alive after amiodarone when you reassessed the patient. Excellent. I think you did well. When the patient has cardiac arrest, so you activated cardiac arrest to call. Excellent. The most likely problem is T thrombosis. Did you mention that?
No, I didn't mention that.
Okay, so you should show the examiner that you catch the cause of the reversible causes. Did you correct the reversible cause? No. How to correct thrombosis?
To call the cath lab.
Either cath lab or thrombolysis.
Thrombolysis.
You should confirm cath lab activated, guys. Cath lab is ready. Maybe you don't have cath lab. How to know that? The nurse will say not available, right?
Yes.
If the nurse in the exam or the examiner in the room did not comment about cath lab, it means available. So don't mention thrombolysis. Clear?
Clear.
If you have ECG before cardiac arrest and the ECG is showing STEMI, you can send the patient to cath lab with mechanical compressor. You can attach the compressor and you can move the patient to cath lab with chest compression. Clear?
Clear.
Okay. So if you can say that, excellent guys, we can attach mechanical compressor and we can move the patient now to cath lab because we have evidence now ECG STEMI. Easy.
Easy.
Then you can continue your approach normal. If the patient needs this shock, give. So you are doing well, but you are missing the most important points, the fatal points. The patient will not return to ROSC without perfusion. Perfusion, whatever mechanical perfusion or pharmacological perfusion. Mechanical BCI, pharmacological alteplase, clear? Or
Clear.
streptokinase. I wish it's clear.
It's clear.
So you missed these points, okay?
Okay.
Otherwise, you are doing well. So I will give you 7 out of 10, okay?
Okay. Thank you.
You have good leadership skills, good resuscitation skills, you are organized, you are doing very well. Oxygen also, don't give oxygen in chest pain, okay? Any chest pain, don't give oxygen because oxygen vasospasm. Oxygen vasospasm. So if the patient has infarction in the heart or infarction in the brain, don't give oxygen until or unless the SpO2 is less than 94. But you give the oxygen without checking the SpO2, right? Okay.
Yeah. That's a
Next one.
mistake. Thank you.
Welcome. Next one. Aton.
Yes, doctor. Assalamualaikum.
Alaikum salam. The next station. You have 30 seconds and 6 minutes.
Okay. Yes, doctor, I am ready.
Okay, you can start.
Yeah. Good morning. I am Dr. Atul. May I know your name and age, please?
I'm Karim. I'm 43.
Nice to meet you, Mr. Karim. How can I help you today?
Yeah, I have burning micturition, doctor.
Oh, sorry to hear that. Do you have any pain?
The nurse gave me painkiller.
Okay. So, I need to take some detail regarding your this problem. Can I take the detail? Hello? Is it okay? Can I ask? Okay, thank you. So you told me you have a this pain, burning during menstruation. Is it correct?
Yes.
Yeah. Can you tell me in detail how?
What do you mean in detail, doctor?
Okay. Can you tell me more about this?
Yeah, the problem started 2 days ago. It
Yes.
started gradual, increasing, worsening, and continuous.
Oh, sorry to hear. So for 2 days you have this problem and onset 2 days back and gradually increasing and it is continuous and worsening. Uh, is it correct?
Yes.
Yeah. So whether it is associated with pain in your tummy?
No, no,
Okay. So you have this burning or micturition, whether it is associated with any blood or reddish urine?
no, no,
Okay. Do you have any? I need to ask some personal question. This whether this is associated with the any discharge from the urethra?
no.
Okay. Uh, okay. I need to take some detailed history regarding this. Whether you're suffering from fever,
No,
anytime fever. Okay. Any vomiting, any
no,
throat. Okay. Uh, do you feel any other like pain in the chest or headache?
no,
Okay. Any lump in the body?
no,
Any decrease in appetite?
no,
Okay. So, any past medical history, medical disease?
no,
Any family history of any disease run in the family?
no,
Any allergy?
no,
Any previous surgery?
no,
Okay. Are you taking any prescribed medication?
no.
Okay. As you have this problem, this complaint, so I need to take some personal sexual history from you. Is it okay? Can I take? Yeah. So, are you doing like normal sexual activities regularly? Are
I think last sexual act was 5 days ago.
okay. So you have sexual act with routine partner or any other except your routine partner?
Yeah, non-regular pattern.
Okay. So, are you have any problem to your partner? Similar your partner have similar problem of burning micturition or
No,
no? Okay. So, okay, and uh, so you have since 5 days back this sexual. Okay. So, to whom will you live with?
was my regular partner in downtown.
Okay. What are you doing for your livelihood?
Receptionist.
Okay. Are you drinking alcohol?
No,
Are you smoking?
no,
By any chance you are having habit of recreational drugs?
no.
Okay. So as you told, you have a regular partner, whether the partner is from same country or different country?
Same country, yes, same area.
Okay. So partner is from same country and sorry to ask you this question, whether you are doing vaginal or anal or oral sex?
No, it was vaginal.
Okay. So did you travel outside?
What do you mean by outside?
Means outside country or something?
No.
No. Okay. So what is your concern?
What is the problem, doctor? Is it serious? Do I need post-exposure prophylaxis or any treatment, any blood test, any admission?
Okay. I appreciate your concern. As per your clinical details, you have these symptoms for 2 days, and this we will do some urine test for you. We will do some blood test, and we will do complete clinical examination from head to toe, including your tummy and your urogenital area. And from your history, you are on not a like you have a regular partner. You are not have more than one partner. It is low risk, and this may be because of some infection in the urine. Probably we will give some antibiotic if there is an infection in the urine, and we will discharge you for follow-up your GP with the safety leaflet uh, uh, along with the leaflet. And if you feel any pain or abdominal tummy pain or vomiting or fever, you can come back to our emergency. Are you able to understand? Hello?
Okay,
Okay.
thank you, Atul.
Okay.
You finished your time. What
Yes.
do you think?
Sir, it's a sexual history I need to take, so it's a low risk group. There is no discharge, and there is no clinical sign that I will send to the gum clinic. So what I plan to do urine test and take the urinary tract infection history and discharge the patient. This was my thought. Rest I don't know.
Okay, so I will talk about the approach first. Regarding the accuracy, you almost mentioned all the points, but organization, not organized. You are fluent, it's okay, but not organized. And the accuracy, you are not following the same approach. I mean, you have three open questions. The first open question, how can I help you? Very simple. The second open question, can you tell me more about that? Okay. So you should follow the same wording. And the last open question, would you like to add anything? Clear, doctor?
Yes, doctor.
Regarding the sexual history, you should ask him in the start, I need to take some data regarding your sexual health from the start. Okay? We will be in private room and with a chaperone.
Okay.
Anything you will tell me will be confidential. You can stop me at any time. Okay?
Okay.
Once you finish Odibara, so Odibara should be complete. You did not ask Odibara incomplete. Okay? Then you will go for sexual history. Sexual history here, it will be also after associated symptoms. Associated symptoms, do you need to ask all associated symptoms? No. Genitourinary and GIT, more than enough. Okay? So the questions of urine symptoms, the questions of genital symptoms, the questions of GIT. Done. Then jump to sexual history. No need to ask about sex B's. You can ask for B's. Okay?
Yes. Yes.
So partner, you should ask how many partner apart from your regular partner, male or female. You did not ask male or female.
Yes.
From different country or not. You ask about this question, but later, and you are jumping to other questions, then go back for sexual. Other questions, then jump again to sexual. Not organized. Pregnancy. Are you trying to get your regular partner pregnant? Protection. Was it protected sex? And the practice. Was it vaginal, oral, anal, or all? So you should work on organization. You are not organized.
Yes,
Okay.
doctor.
Here the patient has no genital symptoms, but he has KUB symptoms, burning micturition here, KUB symptoms. The patient considered asymptomatic from the point of view of genital. Okay. So this patient low risk because only one non-regular partner from same area, from same country, and female. If you ask me, I will say female. And the patient has no anal sex. So this patient, you can reassure and discharge, right?
Yes.
Which is first, diagnosis or management plan?
Management plan and diagnosis and management plan. First is
Diagnosis first.
yes.
But you mentioned the management plan before diagnosis. Is it logic?
No.
You will move the patient, for example, to cath lab without ECG?
No.
No. So every diagnosis should be first. Okay. So you should say, according to your data, you have burning micturition. It could be kidney ureter bladder symptoms, but you don't have any genital symptoms like urethral discharge, genital skin changes, or ulcers. You did not ask about these questions. Okay. For this reason, for this reason, we are considering you are asymptomatic, okay, and low risk to get sexual transmitted infection. You should mention the diagnosis first. Clear? If you
Yes.
want to make the diagnosis reasonable, you can say because you don't have more than one non-regular partner, you don't have anal sex, the partner from the same country. Easy.
Yes.
So diagnosis, better to be reasonable also. Reasonable by clarifying why it's blah blah blah. Okay. Then the management plan. You can say we will manage the burn micturition. We will do examination of your tummy, the genital areas. We will do some blood test, including kidney function test, virology. We will do urine test and manage you accordingly. Done. No need to go deep. Then you can say, I want to reassure you regarding sexual transmitted infection. You don't have any symptoms at the moment, and you are at low risk to get sexual transmitted infection. For this reason, you don't need any intervention like post-exposure prophylaxis. I will discharge you with printed leaflet, discharge letter to your GP. If you have any worrying symptoms like urethral discharge, genital skin changes, or ulcers, you can return back to the hospital. ER. Easy.
Yes.
Or you can say also gum clinic, genitourinary medicine clinic. Okay.
Sure.
I will give you 7 out of 10. 7 out of 10. Okay.
Thank you.
So you should be organized and mention the diagnosis clearly and why is this diagnosis, and then the management plan should be clear. Okay,
Sure.
thank you.
Thank you.
Next one. Anyone did not practice and happy to practice?
Sir, me. Sorry, my hand was not.
Okay, Sondas, your turn. You have 30 seconds and 6 minutes.
Can I start, sir?
Yes, please.
Good morning. I'm Dr. Sundar, CD Registrar. May I know your name and level, please? So we have got a pre-alert that a neonatal baby
Once
is
you go inside the room, once you are opening the door, the nurse is pushing the baby, mannequin baby in your chest.
okay. Okay, no problem. Give it to me. I will handle it in my hand. I want you to please prepare resuscitator so that we can keep him. And mind while doing that, I'm drawing and wrapping it, baby, and stimulating it. I'm putting it in a resuscitator. Staff, please can you activate neonatal resuscitation team? And meanwhile, I will assess the baby for the ABGAR score. May I know the appearance, pulse, grimace, and respiration rate of this baby?
Absent activity and absent floppy grimace, absent pulse, absent respiration, and blue appearance. So the patient is flat.
So, staff, as we can see that the ABGAR is very low, we need to activate the neonatology team and we will start the resuscitation. This baby needs neonatal resuscitation. We will open the baby mouth after drying and stimulating. We will open the baby mouth and will give 5 inflation breath. 1, 2, 3, 4, 5. This will. I will also ask you to can you please see for any IV access. Am I able to see any chest rise?
No chest rise.
Okay, now we will have a 2% technique. And while doing this, we will increase the pressure. We will now attach the oxygen and again give 5 inflation breath to the baby. 1, 2, 3, 4, 5. Is there any chest rise?
No chest rise.
Okay, so we have also failed the 2nd person technique. Now we will go for the intubation for this baby, and while doing that, we will give 30 ventilation while intubating that
Failed
baby, or
intubation. Failed intubation.
failed intubation. Okay, we can have a LMA. Do we have an LMA for this baby? Can we insert LMA? And now can we give 30 inflation breath, 30 ventilation over 30 seconds? Are we appreciating chest rise?
30? You mean 30 or 5 inflation?
Sir, after LMA, 30 ventilation.
5 inflation.
5 inflation. Okay. After, is there any chest rise?
Yes.
Okay. What is the heart rate now? So this patient is in bradycardia. We need to start chest compression, and this will be 3 compression over 1 ventilation. And meanwhile, we will encircle the baby's chest and do the thumb compression over the sternum. And while giving 3 compression, we will give 1 ventilation. Is there any improvement in pulse, heart rate? Okay, so heart rate is still there. We need to also recall our HNTs. Meanwhile, we need also additional help. So HNTs, and also please, if we got the IV access, we need to give this patient adrenaline, which will be 20 mics per kg. After 30 seconds, are we able to appreciate any increase in heart rate? Okay, it's still bradycardia. We need to assess for. We have given the first epi. We need to assess the HNTs, which will include the hypo. We have already taken the airway. Hypoxia is corrected. We have given the epi. We will see for. Do we know the glucose of this patient, please?
Glucose is normal.
Normal. Okay. And meanwhile, we will can start the fluids as well, 10 ml per kg. And is there after 30 seconds, do we have an improvement in heart rate?
What are the causes of this cardiac arrest, doctor?
It could be as he's newborn. It could be any congenital abnormality. It could be we have corrected the hypoxia. There could be any mother history of taking any opioids. So we need to correct all those causes. It could be acidosis. So we can check the BBGs as well. Do we have a heart rate? Any improvement in heart rate? It's still there. So we will continue the chest compression 30:1 ratio, and meanwhile we will be giving epinephrine after every other cycle. Do we have any BBGs? Good team, we have achieved the ROSC now. Now we need to assess the baby from A to E. We have already got and calculate APGAR score. How's the activity, pulse, grimace, appearance, and respiration of this baby?
Active now. Pulse is more than 100. Good response. Pink and crying.
Thank you. So thank you, team. We have got the good APGAR now. Now we will be doing the post-ROS things. That means we have gotten the baby on ventilator. We will need a new neonatologist to hand over this patient. Also, we need to get the samples to rule out any abnormality in electrolytes or BBGs. And also, we need to get a chest X-ray to be sure that there is we are
Thank
not
you,
missing
doctor.
out.
Your time done. Thank you.
Thank you.
What do you think is on this?
Sir, I think apart from that ventilation thing, I was okay.
Okay, let me give you feedback. So this patient is newborn, and here you should understand term or preterm. So more than 32 term. So term here, it means start by dry rab stimulate. Okay? Okay,
Yes, sir.
then start the clock, delay clamping of the, you can zoom guys from your phone, 2 fingers, okay? So here, dry rab stimulate and keep warm. regarding the clamping delay, and then you will assess Apgar score. So number one, assess Apgar score. Apgar score is 0. You should mention Apgar score is 0 out of 10. Don't say low. Clear?
Yes, sir.
Because if low, maybe 8 out of 10, maybe 9 out of
Yes.
10. 9 out of 10, no need for resuscitation, right?
Yes. Yes, sir.
You should say 0 out of 10 or 2 out of 10, like that. Okay, this is the first mistake. Uh, Newborn resuscitation, you should call neonatology team, suction the airway, ask is the chest moving. Then you did not ask the chest is moving or not. And regarding the chest, first action 5 inflation breaths, 1 person technique, each inflation 3 seconds. Then ask again, is the chest moving? If no, give 5 inflation breaths, 2 person technique, each inflation 3 seconds. Head in neutral position, ask, is the chest moving? I said no. Then you can go for LMA, not for intubation. Clear, doctor?
Okay. Okay, sir.
I mentioned failed intubation to force you to go for LMA. Don't say, do we have LMA? In the exam, don't ask do you have or not.
Yes, sir.
You want to do. Clear? Anything you want to do. Easy?
Sir, just want to ask why not we can intubate because of the neonate?
If you want to intubate, no problem. But here in the
Yeah.
algorithm,
Yeah. Okay. Yes.
they said give 5 inflation breaths, blah, 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 blah. Okay. Here regarding if the chest is not moving, you can check mask head jaw position to person support to consider supraglottic.
Rotas air.
Did
Okay,
they
sir.
mention intubation?
No.
No. The intubation in the end.
In
Easy.
the yes. Yes, sir. Yes.
So supraglottic airway here, priority.
Yes, sir.
Okay. Supraglottic
Oh,
airway device, you have opening. Once you have successful LMA, you can pass tube in the LMA. Clear?
yes, sir.
Okay. So here regarding the reversible causes, what are the reversible causes? Blood sugar,
Yes, sir.
hypovolemia,
Hypervolemia,
pneumothorax, congenital abnormality.
congenital.
Did
Yes,
they
sir.
mention here hypoxia?
No.
No, you mentioned hypoxia, no.
Yes.
Okay, so mistake here, okay?
Yes, sir.
So you should say, I will consider the cardiac arrest causes. What about blood sugar? I will consider hypovolemia, the patient already on
Volemia.
fluids. I will consider pneumothorax, any resistance in ventilation, any
Mm-hmm.
congested neck veins, and congenital anomalies. You can consider
Yes.
also. Okay. Hypoxia not important because the accepted oxygen after 3 minutes 70, accepted
Yes.
oxygen after 5 minutes 80, accepted
80.
oxygen after 10 minutes. Can you imagine 10 minutes? 90.
90.
It means
Yes.
hypoxia not the cause.
Mm-hmm. Right, sir.
Okay. So here, maybe once you go inside the room, the nurse will throw the baby mannequin in your lap. Okay. So don't
Yes,
worry.
sir.
Just to hold the baby. You can say to the nurse, be calm. We will start assessing Apgar score and also delay clamping, start the clock, dry rub stipulate. So you should mention all these points. Okay. So in a way, we
Okay,
are
sir.
in the point of chest rise available. Then you will go for the heart rate. Don't jump
Yes.
to ventilation. Ventilation in heart rate, not in chest. Clear? So the
Mm-hmm.
first action, you started CPR. This is wrong. You should start by
Mm-hmm.
30 ventilation.
Mm-hmm.
Okay. So you have mistake here. So
Mm-hmm.
not every bradycardia you will jump to CPR. No. So bradycardia here, you will start by 30 ventilation, each ventilation every 1 second for 30 seconds. Then check the heart rate, still less than 60. Then start the CPR for 30 seconds, high quality CPR. and then check still less than 60, then resume again CPR for 30 seconds. Insert IV access. Don't say umbilical access. You can say IV access. Okay. If the nurse said no IV access, you can say no problem, insert umbilical access. And they give fluids, give adrenaline 20 microgram. If the patient has hypoglycemia, you can start glucose 2 ml per kilogram according to weight flag. And then again, you can consider the reversible causes as we mentioned earlier. Clear, doctor?
Yes, sir.
Okay. Then once you find the heart rate more than 100, it means ROSC. Don't jump to ABCDE. You were about to jump to ABCDE. So you should go for Apgar score again.
Yes, sir.
Apgar score normal, 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 normal. Then you can say Apgar score now 10 out of 10. Excellent. Then I will assess the baby. So you should start by ABCDE. It means airway. What about AVBO score? Is the airway patent? And in breathing, you will ask about 8 points. You can say expose the chest and connect all monitors. The baby born without colossus. Why I will say expose the chest and connect all monitors? No problem, because in the start you said dry, wrap, stimulate. So you covered the baby by towel in the beginning. That's why again after ROSC you should say expose the chest and connect all monitors. Clear? Then you'll ask about 8 points, circulation 4 points, disability 4 points, and exposure 2 points. In breathing, you will catch the main problem, whatever, if pneumothorax or congenital anomalies or hypovolemia or any problem. Okay? I will give you 8 out of 10. Thank you.
Thank you, sir.
You have some mistakes. I give you the feedback. I wish you learn from these mistakes.
Yes, sir.
Okay.
Thank you.
Welcome. The next one, who is happy to practice? Anyone did not practice? You can raise your hand, guys. Otherwise, we will go from the start. Sheikha,
Yes, doctor.
you have 30 seconds and 6 minutes.
Okay. Okay, I'll start.
Yes.
Okay, good afternoon. I'm Dr. Sheikh Eid Registrar. What's your good name and what's your good name?
Nasser?
Hi, Mr. Nasser. Nice to meet you. How can I help you today, Mr. Nasser?
Yeah, I collapsed today, doctor.
Oh, I'm really sorry about that. Just to clarify, do you mean you lost consciousness or that you feel dizzy?
I lost my consciousness.
You lost consciousness. Oh, I'm really sorry for that. Okay, Mr. Nasser, I'll shift you to the resus room just to connect you to the monitor and take vitals and check the blood sugar to make sure you're okay. Okay, and I'll be taking some data about what happened. Is that fine? Okay. So can you tell me more about what happened, Mr. Nasser?
I was watching TV in the living area and suddenly I collapsed.
Oh, I'm really sorry this happened. And before I just proceed, Mr. Nasser, are you in any pain? Do you need any painkiller? Are you comfortable?
I'm okay.
Okay, Mr. Nasser. So you said that you were sitting in the living area and you collapsed. Is that correct?
Yes.
Okay. Did anyone see the event?
Wife.
Okay. And you said it happened in the living area already. So, um, did this happen before, or was it the first time?
First time.
First time. Okay. And you before that, you said you were only watching the TV before the event. So before you lost consciousness, did you feel any chest pain or heart racing?
Yeah, I felt some heart racing and chest discomfort before that.
Oh, I'm really sorry. Did you feel any? Did you had any visual changes or weakness or headache before the event?
No.
Okay. Did it happen after standing?
No.
Okay. And did you cough or sneeze before the event?
No.
Okay. During the event, Mr. Nasser, did you have any jerky movements, or did you first jerky movements? Was there or no?
Yes, but for my hands.
On your hands, okay. And were there any? Did you wet yourself or bite your tongue?
No.
Okay. And we already mentioned that you completely lost your consciousness. Did you recover fully or not?
Yes,
Yeah, okay. And how long did it take for you to recover fully?
20 seconds.
20 seconds. Okay. Okay, Mr. Nasser, did you have any numbness or weakness in your limbs after the event?
No,
Okay. And did you have any shortness of breath after the event?
no,
Any temperature or trauma?
no,
Okay. And any urinary changes or bowel changes?
no,
Okay, Mr. Nasser. And no skin changes, or is there any skin changes?
no,
Okay. Okay, Mr. Nasser. Do you have any prior medical history?
no,
Okay. Any prior surgical history?
no,
Any allergies?
no,
Any medicines you take at home?
no,
Okay. Any problems that any medical problems that run in the family?
no.
Okay. And Mr. Nasser, what do you do? What do you do for a living?
Receptionist.
Receptions. Okay. And where do you live and whom do you live with?
My wife downtown.
Okay. And do you smoke, drink alcohol, or by any chance use illicit drugs?
No,
Okay, Mr. Nasser. Would you like to add anything else?
no.
Okay, Mr. Nasser. What is your concern, Mr. Nasser?
Is it serious? Do I need any head imaging or admission?
Okay, Mr. Nasser. So, according to the data I collected today from you, given that the loss of consciousness happened, before that you had chest pain and chest discomfort and palpit or heart racing before the event, and you recovered fully, and it only remained for 20 seconds, which is quickly, and you fully regained consciousness. So these factors, they go with cardiac, that the cause is most likely related to your heart rather than the brain. So for that, I'm gonna keep you here in the resuscitation room, and I'm gonna continue my head-to-toe examination. We're gonna check. We're gonna examine your the chest, your heart, and the brain with the back of your eyes, and we're gonna do a full neurological exam, and we're gonna do full labs today, including heart function and biochemistry and blood tests and toxicology screen and all these labs. And I'm gonna do for you heart racing also, heart tracing. Okay, so I received your heart tracing, Mr. Nasser. I am sorry to tell you that it shows some changes that are serious. It is showing a syndrome that is called Brugada syndrome. This syndrome is usually it happens when there is a problem in the sodium channels, which causes a problem in electrical conduction in the heart. So this is a serious problem. I'm sorry to say that. So for that, you would need admission today, and we will call the cardiologist, because you would need to he would need to put for you an implantable cardiac defibrillator, so that this will prevent any arrhythmia from happening and any further
So I will
collapse
go
from
home?
happening. No, Mr. Nasser, you will be admitted today,
Okay,
and
thank
we
you.
will call the
You're done.
cardiology.
Thank you, doctor. Okay. Okay, excellent, Sheikha. I will give you 10 out of 10. So you did very well. Here, you were late when you mentioned heart tracing, and I thought you will forget heart tracing, right?
No, I was gonna say it, but I said the labs before. I took some time in the labs. I was,
Okay.
yeah.
You did very well. Here, regarding the accuracy, you mentioned all the points. Supportive. You are asking questions in pieces, pausing, information in pieces, and pausing. Accuracy 100%, and the skillfulness, you are very fluent. Efficiency, structure, organized, and the safety, correct information. So you deserve a 10 out of 10. Excellent, thank you.
Thank you,
So
doctor.
you did introduction, but you did not ask about the age. What is your name? You said, may I know your name? You did not say
Mm.
age. So you
Oh,
should
yeah.
confirm the name and the age, okay?
Yeah.
3 open question you did, and Socrates, who approach you did, okay. Excellent. You ask all the questions, and the general approach part 2. Thank you. You are perfect. Next one,
Thank you, doctor.
Abbas.
Yes, sir.
You have 30 seconds and 6 minutes. You can start.
Hello, my name is Dr. Mohammad Abbas Khan. I am the head registrar here. May I confirm your name and level, please? Okay. Kindly prepare airway equipment for me and circulation equipment for me. Are you APLS provider? A patient is about to arrive. Has the patient arrived?
Patient arrived.
Okay. Is the baby conscious?
Doctor, this is my son. What happened, doctor? It's okay.
Don't worry. This is in our safe hands. We will resuscitate it. Okay. Is the baby conscious?
Seizing.
Okay. Okay. The baby is seizing. Kindly call the neonatologist and see a team. This patient is seizing, and this patient needs early intubation. Kindly. What about the airway?
The airway is not
Is the
patent.
airway is not patent? Kindly clear the airway. Put
Doctor,
the
I cannot open the mouth. The baby is clenching the teeth.
Okay, no problem. Put the big valve mask and connect it to oxygen. Okay, kindly expose the chest and okay, connect all the monitors. What about SpO2 and respiratory rate?
SpO2 is 94, RR is 30,
Okay, what about trachea and neck veins?
normal,
What about inspection, palpation, percussion, auscultation of the chest and lung sounds, heart
normal,
sounds?
normal.
Okay. So the findings are normal. We will move to the C. What about the blood pressure, CRT?
Blood pressure normal, CRT normal,
Okay. What about peripheral veins and heart rate? Okay. We can see that the patient is having a sinus rhythm. Any look, listen, feel any signs of life?
Yes, I told you the blood pressure normal.
Okay. Nurse, kindly put IV cannulus too and take the blood for the hematology, biochemistry, blood case, blood culture, toxicology screen. The patient, this patient is seizing and is continually seizing for more than 5 minutes. So this is status epilepticus. Kindly start the alprazolam, lorazepam, 5.5 milligram state. Okay. Now I will move to the D. What about EPGAR score? Okay. What about any signs of lateralization?
Apgar score
Okay.
in newborn, not in this age. This age is 3 years.
Okay. So what about the GCS, sir?
Avga score, seizing,
Okay. And any signs of lateralization?
seizing,
Okay. People size?
unequal.
Unequal and RBS?
Blood sugar is
Okay.
15.
Okay, the blood sugar is 15, so there is hyperglycemia and unequal pupils. So this means that the patient is having and raised intracranial pressure. This may be due to the DKA. So kindly call the ICU team, pediatric ICU team, and we kindly start this patient on mannitol IV state, and what I will move to the E. Kindly expose the body and any other abnormality. Okay, and what about temperature? Okay, okay, as the ICU team arrived, okay, this patient is received in seizing patient is seizing, and we will reassess the patient. What about the airway?
Airway is patent.
Or is patent? What about his PO2 respiratory rate? Okay. What about the blood pressure and CRT?
Doctor, we tried to insert the IV access 4 times. We couldn't.
Okay, no problem. Kindly access the intraosseous in the side and proximal tibia, and give the second dose of lorazepam. 5 minutes passed. Okay, and 0.5 milligram. So is the patient still seizing?
Yes.
Okay, we will start the second line drugs. I kindly start IV levetiracetam, 30 milligram state IV. Okay, is the patient still seizing?
Yes.
Okay, we will go for the RSI, rapid stick sequence induction with thiopentol, and we will. Is the patient still seizing?
Yes.
Okay, we will kindly has the anesthesia team arrived? We will hand over this patient for the ICU team.
Okay, thank you, doctor. Okay. So,
Okay.
thank you, doctor. Your time done. So
Yes, sir.
regarding the station, 3 years is ABLS, not neonate, not newborn. Newborn, it means 24 hours. Clear?
Yes, sir.
So you should understand the category, number one. So this is resuscitation. The which resuscitation? Is it newborn? Is it ABLS? Is it ALS? Is it ATLS? You should ask yourself. Clear?
Yes, yes.
If you say neonatal team, it means you are not concentrating.
Yes,
So
sir.
this 3 years pediatric ICU team. Okay?
Yes. Yes.
Okay. So this patient has seizures. It could be because of DKA, I mean hyperglycemia. It could be because of hypoglycemia, the other way around. It could be because of head injury, if they mention in the scenario trauma. It could be of epilepsy, whatever past medical disease of epilepsy, or new onset epilepsy, new diagnosis, right?
Yes, sir.
Okay. So you have already clear cause in the disability. Don't start anticonvulsant. I think you did this station before and you have the same mistake and I give you the same feedback.
Yes, sir.
I remember. My
Yes,
memory,
sir. Yes.
alhamdulillah, good. Okay.
Much,
So
much.
So here regarding this patient, in airway, you ask first question you said about the airway. What is the first question in airway?
uh, ABPU scores.
Can you see the
Yes,
slide?
sir. Yes, sir. Yes.
So in any airway in pediatric, you should ask about AVO score, not
Yes,
the
sir.
airway. Okay? Why? AVO score, if the patient if the patient is alert, it means stable. If the patient
Yes.
is V responding to verbal, it means unstable. B unstable. U unstable. What else? B and U needs intubation. Clear?
Yes, sir.
Why I'm asking about AVO score? Number one, I want to know stable or not. Number two, I want to see he needs intubation or not. Clear?
Yes, sir.
So the patient is seizing doesn't mean he needs intubation.
Yes, sir.
Doesn't mean he needs intubation. Not every patient with seizures needs intubation. Okay?
Yeah.
So you will insert nasopharyngeal and back valve mask. So clear the airway, nasopharyngeal airway, high flow oxygen, non-rebreather mask or back valve mask. It's not a big issue. Clear? Okay. Well
Yes.
done. Then in breathing, you will ask about the points. Most likely will be normal because he has no problem in breathing. And then in circulation, the 4 points. The patient has this ECG. You should comment on the ECG. Is this normal for his age or not? You should say the heart rate
Yes.
is almost 75 or 77, normal for his age. Clear?
Yes, sir.
If normal, mention normal. If abnormal, mention abnormal. Bradycardia. Clear? Okay. So the ECG is normal in child because child more than 1 year. Okay. Then you will give the patient fluids. In D disability, don't assume the patient is still seizing. You said status epilepticus, and you are assuming the patient has seizures more than 5 minutes. Did you ask me? You did not.
Yes.
So you should ask me in disability. What about AVBO score? Is the patient still seizing? If I said yes, continue assessment. Don't stop. You should finish all the 4 points. Clear? So the four
Yes.
points in disability, AVBO score not enough. You should continue number 2. You should say any signs of lateralization apart from seizures, because seizures is lateralization also. Clear?
Yes. Yes.
So maybe the patient has hemiplegia or hemiparesis. Pupils is part of lateralization. You can ask what about pupils? Equal reactive. So the pupils here unequal and the patient has high blood sugar. So it could be DKA. It could be. We have no evidence yet, right?
Yes, sir.
Maybe the patient has hyperglycemia because of the seizures. So any stress or any activity in the body raise the temperature, raise the blood sugar. Clear?
Mm. Yes.
Any activity, any stress raise the blood sugar. This is normal in all people. Okay. So you should confirm by blood gases. If you find the blood gases, metabolic acidosis and lactate may be high also, it means decay. So you should treat the TKA first. If you treat the TKA, no more seizures. Easy.
Yes, sir.
So you should give uh, mannitol if the blood pressure is normal or high. You should give hypertonic saline if the blood pressure is low. So I give you the blood pressure is normal, right?
Yes,
So
sir.
you can give mannitol here. Mannitol will
Yes.
be 1 gram per kilogram according to weight flag.
Yes.
Over 15 minutes or over 30 minutes, both accepted. Okay.
Yes. Yes.
I was planning to make the blood pressure will be normal and the seizures will stop after controlling the DKA. You have non-pharmacological and pharmacological in D. Non-pharmacological, you will raise the head of bed 30 degree. You will intubate the patient for controlled ventilation. Okay.
Mm.
Attach to back valve mask, one ventilation every 3 seconds, and ask about the 4 points. What about chest rise? What about auscultation? What about ETCO2 and SpO2? I was planning to tell you normal, clear,
Yes, sir.
after intubation, and you should insert IO if the nurse cannot get IV access, should insert IO access, and mention the landmark, 2 centimeter anterior medial to the tibial tuberosity. Okay. So here, once you do non-pharmacological management and pharmacological management for raised intracranial pressure, the pupil will change, will be equal, the hemiplegia will be normal, and the seizures will stop also. If you find the seizures continue after treatment of DKA, non-pharmacological and pharmacological, you can start the first line anticonvulsant. I mean diazepam or lorazepam, 0.1 milligram per kilogram. Clear, doctor?
Yes, yes.
Okay. I will give you 7 out of 10. Thank you.
Thank you.
Next one, Michael.
Dr. Hani, sorry to
Yes,
disturb.
please.
Just one question. I never understand in the DK patient why they are giving mannitol or hypertonic saline because of increased raised intracranial tension. You told, I think.
Not DKA. We are
Uh,
giving this for raised intracranial pressure, not for DKA. The
okay.
patient has DKA and has unequal pupil, so the patient has cerebral edema. Clear, doctor?
Yes. Okay. So as a cerebral edema.
Yes, not for DKA.
Okay.
DKA treatment for pediatric fluids. Fluid,
Yes.
not insulin. Fluids.
Okay.
Okay.
Insulin dextrose we are not giving for pediatric only
After
fluid
1 hour.
after 1 hour. Okay.
After 1 hour, it means the ICU team, not emergency. Do you think the baby will stay with you for 1 hour? Once you start the treatment, you call the ICU team and they will admit the patient.
Okay. And
Clear?
doctor, fluid also it is only 10 ml per kg or we can increase in.
Fluids for DKA, not for DKA with complication.
Okay.
DKA with complication, it means you will start hypertonic saline if hypotension or mannitol if hypertension.
Okay.
Don't
Thank you.
give normal saline. If
Okay.
DKA only, normal saline.
Okay.
If DKA only, it means equal pupils and no hemiplegia. The patient is moving the four limbs. The patient has equal pupils. Clear, doctor?
Sure. Thank you, doctor. Thank you a lot.
Welcome. Next one, Michael.
Yeah. Hi, Dr. Hani.
Yes. The next station. You have 30 seconds and 6 minutes. You can
Okay.
start.
Yeah. Hello. My name is Dr. Koya. I'm one of the ED doctors. Are you Feha's mom? Please confirm if you're Taha's mom. Can you hear me?
Yes, if the actor is silent, proceed, doctor.
Okay. Thank you. I understand you've brought Taha. You've got some concerns. Could you just confirm his age for me?
Yeah, my son is 4 years and I'm Noel. I'm the mother.
It's fine. How may I be of help today?
Yeah, my son is with your team now.
Okay, right. I understand you're concerned about a sore throat. Is that right? Okay, so you've brought your son with a sore throat, and we've examined him, and I'm just here to ask you some questions about him, if that's all right. Okay. So, have you got any sort of particular concerns about him?
No, doctor, just give him painkiller.
Okay. That's all right. We can sort that for him. While we're assessing him, we've also made some additional discoveries, and I was just going to ask you some questions and to ascertain how that must have happened. We realized he's got some bruises, and he's had an X-ray that showed he's got a fracture of one of the bones in his arms. Have you got any idea as to how that must have happened?
No.
Okay. Just a few more questions about him. Who takes care of him?
Why you are asking these questions, doctor? I said he has throat pain. Why you are asking me this question?
Right. So like I said, we made some discoveries while we're examining him. We realized he's got some bruises. So we're just going to ask to know if you have any ideas how they've happened.
So are you accusing me?
So no, that's not the goal of this. Okay. I'm sure you'll agree with me that we both want Saha to be safe. And the reason we're asking this is to understand how he must have sustained these injuries so that we'll give him the care that he needs. Okay, so I'll just ask you again. Apart from yourself, is there any other person that takes care of him?
He's living with me.
Okay, so he lives just with you, yeah. Has he ever had any other injuries in the past?
No,
Okay, and is he normally well? Has he got any medical problems?
no.
And what's the home situation like?
What do you mean?
I mean, do you live in the flats? Do you live in a whole house? What's your living situation like? Have you got other children at home? Okay. So just a couple more questions. You mentioned he's normally fit and well, and I understand he hasn't got any bone problems. Are there any medical problems that run in the family? Okay, that's fine. So again, like I said, we've examined him and we found out some things that we're just not sure how it happened. And from what you've told me so far, and it appears you haven't got any ideas how he sustained these injuries. So what we'll need to do next would be to keep him in hospital. First of all, here in ED, we need to keep him in the observation room to do a proper examination of him. And thereafter, we'll need to admit him in hospital so that we can look into these injuries further and ascertain how they must have happened. Are you with me so far?
Okay.
Have you got any questions or objections at all?
So you can give him a painkiller and manage his problem, doctor, and we can go home.
Yes. Well, yeah, you're right. We give painkillers to help manage children's pain. But again, more importantly, because we don't know how he's sustained these injuries, it's important that we do some more investigations, which will include checking if he's got other injuries and getting social services involved to do some more, to dig a little bit deeper and understand why this has happened.
I'm not satisfied. I will take my baby and leave. The mother is waiting at the door of the room now, looking at you.
Do you understand what the reasons I've adduced for wanting to keep him in hospital? Okay, unfortunately, we're not going to be able to let you take him home.
The mother left. You cannot see her at the door now.
Okay, so if the mother's left, I'm going to inform the police. Obviously, this child is at risk and I can't let her.
Thank you, doctor. Thank you, Michael.
Okay, thank you.
Okay, well done, but you have confusion here in this station. This station, like any station, what is the complaint here?
This is a sore throat.
Throat pain, right?
Yes.
What is the approach?
I started with asking you what brought you to hospital, but you kept quiet.
Doctor, please, I ask you, what is the approach for throat pain?
Socrates.
Socrates. Did you follow Socrates? No. Okay. And then associated symptom. What is the most relevant system here?
It's ENT and CNS.
Musculoskeletal and CNS. You did not ask that. You jump to diagnosis. What is the diagnosis in this case? Contusions and fracture, right?
Yes.
This is the diagnosis. Diagnosis in the end of the station, not in the start, right? You jump to diagnosis. You want to jump to the management plan. You did not take history. You should take history first, right?
Yes. Yes.
So you have three open questions. May I know your name and relationship with the patient? Blah, blah, blah. If she answered, say, nice to meet you. If she did not answer, say, nice to meet you, right? If the actor in the exam not answering or um, voice is not clear or you did not understand the accent or the actor his voice very low you cannot hear, just say nice to meet you. Easy.
Easy.
Don't repeat the question again. Okay, are you following me, doctor?
Yeah, I can hear you. I can hear you clearly.
Okay, so number one, how can I help you? Then nice to meet you. Then how is your baby? Is your baby comfortable? Does he have any pain at the moment? She said, for example, he is with your team. Okay, good to hear that. Then you will go for the next open question. Can you tell me more about that? Okay. Then repeat what she will say. Then you will go for Socrates. Okay. Once you finish Socrates, go for musculoskeletal and CNS. These are the relevant system for the real problem, broken humerus. You will ask about any numbness, any weakness, any trauma. Okay. Then CNS, any vision problem, any jerky movements, any loss of consciousness, any headache, like that. Then you will go for other points, other points of the approach, general approach part two. So you have here general approach part one, then Socrates, then associated symptoms for musculoskeletal CNS only. No need for other systems. Then general approach part two, any past medical disease, any previous surgery, any prescribed medicine, any allergy, any disease running in your family. Then prenatal, natal, postnatal, any problem in pregnancy, what about his delivery, any admission. You should pause between each question. Don't ask all questions one shot. Is he growing normally? What about his immunization up to date? You are missing some questions. Then social history. Okay. Whom does live with him and where does he live? Anyone who live with him, smoke, drink alcohol, by any chance use any illicit drugs? What do you do for a living? What about his father? Any carer at home? Any child at home? Then would you like to add anything? Then concern. Then you can tell her the diagnosis. Your mistake, you mentioned the diagnosis very early, or you were about to mention the diagnosis very early. Okay. So in the end, you can say, according to your data, he has no trauma. Unfortunately, our team, they examined him. They found some contusions in his arm, and they did X-ray. They found a broken humerus bone. I'm sorry to say that. Then you can say, for this reason, we are considering non-accidental injury, no reason for the fracture, and this long bone in this age group needs high power to break it. So for this reason, we need to admit him, and then give him painkiller, call the bone doctor, orthopedic team to do back slab for him, and then you will do complete imaging from head to toe, complete blood tests to rule out pathological disease as well, and do complete physical examination, of course. Then call the pediatrician and the social services. Clear, doctor?
Yeah, it's clear.
So the station is usual station, history, pediatric, normal station like any station. I wish it's clear. I will
Yeah.
give you 7 out of 10. Thank you.
Thank you.
So if the mother at the door, you can say, please be calm, have a seat, please. We are here to help you and we are here to support you. I think you agree with me. For the safety of your son, we should admit him. You can convince her by good way, gentle way. Okay, don't say any bad word. And if she went you can pretend that you are calling security, not calling the police. The security will call the police, not you. So you can say, you can put your hand on your ear, pretend that you are calling, be calm in the room. Some doctors will go behind the actor. This not professional. It's not your task to touch the patient. You, doctor, deal as a doctor. Don't go behind the patient. Don't touch a patient. Don't touch a patient. It means don't touch a patient. I mean, don't fight patient. Don't argue with patient. Don't raise your voice with any patient. You are doctor. If you are silent, this raise your image, raise your value. If you are sitting calm, this raise your value. Don't think if the patient is shouting or saying bad words, you will do the same. You will get your right by your hand. No, this will make you uh, not a doctor. So be calm, sitting in your chair, and just pretend you are calling the security. You can say, I'm calling security now. Please, I'm giving you details of one absconded patient, non-accidental injury. Please check the camera or check the CCTV and prevent this patient from leaving the hospital. And if you can call the police, I appreciate that. Is the doctor?
Yeah, easy.
Okay. So I will give you 7 out of 10. Thank you. Next
Thank you.
one,
Atul.
Aton. You have 30 seconds and 6 minutes. You can start.
Good morning. I am Dr. Atul. May I know your name and grade, please? Thank you. Uh, I believe I have a patient coming for stab wound chest.
Patient arrived.
Okay. Any endorsement from the crew?
The patient has accident and he fought with the other driver.
Okay. Any medication given to the patient? Okay, thank you. Just patient, first please do manual inline stabilization. Whether the patient is conscious.
The patient is unconscious.
Hello, hello. Is there any pulse?
Yes.
Okay, patient is unconscious. Please check the airway. Airway is patent.
Patent.
Okay, please attach high flow oxygen with non-rebreathing marks. Check for the chest rise. Okay, please attach the monitor over the chest. Keep one, what is the SpO2?
9. SpO2 is 80.
80. What is the respiratory rate?
50.
Trachea?
Deviated to the left side.
Deviated to the left side. Okay. Neck vein engorgement?
Yes.
Okay. Okay. Any inspection of the chest? What is the finding?
You will find a stab wound object in the chest
On the right or
and in the right side.
Okay. And on percussion? Palpation?
Percussion stone dullness right side. Palpation decreased chest rise right side and decreased chest rise in inspection as well.
Okay. So team, this is this is maybe a hemothorax over the right side. Patient has just please arrange the chest tube and need to insert chest tube on the safe triangle over the right side. And please activate the trauma team and place the on placing chest tube in the safe triangle over the fifth intercostal space. Whether the blood is coming or anything coming.
Yes.
Okay, just check the how much ml of blood is coming.
1600 cc.
Okay, this is a significant amount. Please activate, call the cardiothoracic surgeon, activate the massive transfusion protocol, and take the blood pressure of the patient. How is the blood pressure?
Blood pressure is not recordable.
Not recordable. Please attach the both side wide bore cannula. And do we have a negative O negative blood? Please, do we have O negative blood? Please take the blood for the blood venous gas sample and lab test, CBC renal function test, and take the start the blood. Whether the pulse is there, blood pressure is not there, pulse is there.
Yes.
Okay, how is the pulse? Okay, it is a tachycardia. Okay, peripheral pulse is feeble or normal?
Weak.
CRT?
Weak.
Okay. As 1500 ml or 1600 ml, how is the oxygen saturation now? Whether it improved?
Saturation is not reading.
Oxygen saturation not reading. Okay. Sign of life again?
Yes.
Yes, sign of life is there. We started blood from both the sides. Okay. Give tremexic acid 1 gram. And regarding the wound, whether any bleeding from the wound?
No.
No. Okay. Trachea is now central or after this passing of 1500 ml fluid? Trachea is central. Neck veins engorgement improved.
The trachea is central and
Okay.
the neck veins are flat.
Neck veins are flat. Okay. So I think that this is a case of hemothorax with so that is improved. So we already started blood. Okay. So it is a hemorrhagic shock, traumatic hemorrhagic shock, and going to the abdomen. Any injury of inspection? Any abdominal injury on inspection?
Normal.
Normal. And a fast scan, any positive or negative?
Normal.
We have fast, normal. Going to disability, whether the patient is conscious, GC scale?
9.
9. Okay. Any sign of lateralization?
Normal.
Blood glucose?
Thank you, doctor.
Okay.
What do you think, Ato?
I am able to recognize hemothorax and
You are in C. You did
yes.
not reach D, you did not reach E, you did not hand over the patient to the team, you did not reassess the patient, you did not optimize the oxygen, you did not optimize the circulation, you are slow, you are not organized. Okay. So here in introduction, try to be very brief. Good morning, I'm blah blah blah. May I know your name and the grade? Nice to meet you. Prepare airway and circulation equipment. We are waiting for patient with a stab wound in the chest. Then patient arrived. I need to take handover from ambulance crew. The patient has blah blah. Thank you. Then airway is the patient conscious. Is the airway patent? Then go for breathing. Expose the chest to connect all monitors. Ask about the 8 points. What about SpO2 or artery neck veins inspection, palpation, percussion, auscultation? Like that. To save time. Clear, doctor?
Okay.
Work on memorization. Do effort. Paper and pen and write. Write many times. 1 hour per day, enough to get 160 out of 160 in the exam. Clear, doctor?
Sure.
You have problem in organization in history? For sure, you will get problem in organization and resuscitation. You will get problem in organization and all station.
Okay.
Every doctor have problem in anything, he will get the same problem in all, because organization, it means you should do effort, at least 30 minutes per day, enough to pass the exam. Easy.
Okay.
Memorize the general approach. You have problem in the general approach. If you have
Okay.
problem in the general approach, how you will pass? Clear, doctor?
Yes, doctor.
So you should ask in breathing by this way. Expose the chest to connect all monitors. What about SpO2, RR, trachea inspection, palpation, percussion, auscultation? Done. Few seconds. Okay.
Okay.
Good memorization, good organization, saving time, confidence, professionalism, calm, everything. Clear?
Okay.
So here, after asking the 8 points in breathing, 8 points, it means full assessment. If you ask about the 8 points, it means you ask about full assessment. Then full findings. Full findings you did not mention. You mentioned hemothorax. Hemothorax is diagnosis. Diagnosis after the findings. The last point in findings, diagnosis. You should say the patient has stab wound in the right side of the chest, tachypnea, hypoxia, deviated trachea to the other side. It could be, and stony dullness in the right side. It could be massive hemothorax, not hemothorax. Is it hemothorax or massive hemothorax?
It's a massive hemothorax.
Massive hemothorax. You mentioned the diagnosis, incomplete diagnosis, and you did not mention the finding. You should explain to the examiner why you expected massive hemothorax, right?
Yes.
So stab wound in the right side of the chest, stone dullness, and deviated trachea to the other side, tachypnea, hypoxia. It could be massive hemothorax. This how to be organized. Clear, doctor?
Yes.
Then full call. You did not call. Call the trauma team, cardiothoracic surgeon. You jump to chest drain. You jump to intervention. You are not organized.
Okay.
So full call. Call the trauma team, cardiothoracic surgeon. I want you to care about call before your intervention. Call once the nurse will give you the chest drain and already you called the cardiothoracic will come and insert the chest drain instead of you. Easy.
Okay.
But if you are not calling the cardiothoracic and you ask the nurse to insert, maybe you are not competent to do that. You are wasting time and the patient will die. Clear, doctor?
Yes, sir.
So for the purpose of the exam, for the purpose of the real practice, you should be organized like that. So first of all, call trauma team, cardiothoracic surgeon, activate massive transfusion protocol, and prepare theater. Did you prepare theater?
No.
No. So you have 4 points now in call. You are ignoring everything. Okay. Then intervention. Intervention, you will insert chest drain where? In the fifth intercostal space, maybe the stab wound in the fifth intercostal space. Did you ask the site of the stab wound? No.
No.
You should ask where the object. Okay. You should say keep the object. Don't touch the object. You should verbalize that. You should emphasize on that. So if I say the stab wound in the fourth intercostal space, insert in the fifth intercostal space. Okay. If I said in the
Okay.
fifth, insert in the fourth. If I said the wound in the fifth and the fourth, insert in the third. Easy?
Yes.
Okay. So you will insert the chest drain connected to underwater seal. Any blood? Yes. How much? 1600 cc. Then you can verbalize this indication of ED thoracotomy.
Okay.
Clear? And then ask about the 3 points again. Don't jump to circulation and then jump to breathing again to ask about trachea. No, you should ask about trachea, percussion, and oxygen saturation immediately after inserting chest drain. Clear, doctor?
Yes.
So once you insert chest drain, you should ask any blood? Yes. How much? Blah, blah, blah. What about trachea? Improved? What about oxygen? Improved? What about percussion? became resonant, like that. Then jump to circulation. Circulation, you should ask about 9 points. You did not ask about the 9 points. You're asking about some and make intervention. Ask about some, no, you are not organized. So in circulation, you should ask about how many points? 9 points. What about blood pressure, CRT, peripheral pulses, heart rate, abdomen inspection, palpation? What about pelvis stable? What about lung bones? Any deformity? Then what about fast? Any free fluid collection in the four views? Easy, doctor?
Yes, doctor.
By this way, okay? Don't ask for points only. No. 8 points? No. 9 points. Okay?
Yes.
9 points, then findings. You should say, after the 9 points, you should say, the patient has hypotension. It could be hypovolemic hemorrhagic shock.
Yes.
These are the findings because of the massive hemothorax in the right side. This is the diagnosis. Then
Yes.
call. Already you called. Already you called. So you can confirm. Is that trauma team arrived and
Yes.
cardiothoracic arrived? Theater prepared. Then intervention. Do you need to do any intervention in the C? Yes. Insert two IV access, extract blood for hematology, biochemistry, blood gas, blood culture, toxicology screen, and give the patient 4 units bagged RBCs, not all. Give the patient what? 4 units, same blood group, 4 units bagged RBCs. Doctor, you should start by same blood group. Clear?
Yes.
You said, oh, negative, available. Don't ask available or not available. You want to give, give.
Okay.
Your duty to give. The nurse or the examiner, their duty to be silent or to say not available. Easy.
Yes.
If the examiner or the nurse are silent, it means given. If the examiner or the nurse said not available, jump to the next action. For example, they said 4 units back the RBC is not available. Then give all blood group according to the gender. The gender here is male, so you can give O positive blood group. It will be 2 units. If the examiner is silent, it means 4 units back the RBC is given. Don't say available or not. Okay.
Okay.
So we finished now circulation. Then you will go for disability. Ask about the 4 points. Then exposure 2 points. Then I need to hand over this patient to cardiothoracic surgeon. This patient needs it is thoracotomy. Okay. Then you go for airway. Ask again, is the patient conscious? Is the airway patent? In breathing. In breathing, you can ask about the most important points, abnormalities, like SpO2. What else? RR, because you're inserted chest drain. What else? The trachea deviated or not? Okay. The blood, the blood in the underwater seal. Why? Before it was 1,600. If now stay 1,600, it means no worries, right?
Yes.
If the patient has 1,600 and in reassessment 1,600, I'm happy. Okay. But if the first one 1,600 and the second assessment 3,000 cc, I will be afraid, right?
Yes.
Like that. So in second breathing, you should ask about SpO2, trachea, and the percussion, and then the underwater seal. Underwater seal working or not working? Okay. So swinging, even in massive hemothorax, yes. And also how much blood. Okay. If if the blood volume or the blood in the underwater seal same and it's working, I will not be afraid. But if not working, maybe malposition or maybe occluded. Okay. Well done. So here you should finish all the points, discuss with your team also. In the end, if you still have time, you can say we are waiting for the trauma team cardiothoracic surgeon. This patient needs blah, blah, blah. Okay, I will give you 7 out of 10. Thank you, doctor.
Thank you, doctor. Wow.
Anyone did not practice and is happy to practice, guys?
Yes, please.
It is okay. So here regarding massive transfusion protocol, you should start by 4 units RBCs. 4 units bagged RBCs. Okay, same blood group. Then in second blood pressure, second circulation, you should ask if it is then systolic, normal systolic, then you can go for primary bag. It means 4 units packed RBCs, 4 units of fresh frozen plasma, 1 unit platelet. But you should ask about any blood results first. If the examiner said no blood results, give primary bag full. If he said blood results available, correct the abnormalities. Then ask about blood pressure again. If it's still low, ask about blood results again. Correct the abnormalities. If no blood results, then give secondary bag full. Okay. Edis, you have 30 seconds and 60 minutes.
All right. Hello. I'm Dr. Edith, one of the emergency doctors. May I know your name and your age, please? All right. Are you Mr. Hardy? I'm here to take some data from you to see how best we can help you. All right. We'll be in a private room to have this discussion. Every discussion we are going to have will remain private between the both of us, or else when there is a risk of life at stake. You mind telling me why you're here today, how I can help you?
I feel bad.
That sounds quite concerning, even from the tone of your voice. But you're already here. I will have a chat with you, we'll assess you, and we'll see how best we can help, all right? Can you tell me more about your feeling, please?
I'm terminated and my partner, she left me.
Yeah. That sounds like you've gone through a lot, but you're here to support. For how long has this been going on?
1 month.
Yeah. And then if I ask you about your mood at the moment, out of 10, what will you give it? Has this been getting worse, or it has remained the same since this 1 month?
Yes.
Is there anything you do that makes it get worse, your mood?
I told you I'm terminated and separated.
Deeply sorry to hear that. Do you still get a pleasure in your normal day-to-day activities, if I may ask? How about your sleeping? Are you able to sleep at all?
No.
We are here to support you, okay? Just a few couple of questions. Let's see how we can help you. Do you know where you are, if I may ask, please?
Hospital.
What? All right, good to know. What time of the day is this? Morning, afternoon, or night?
Evening.
Good to know. And then, who did I say I am? Can you remember?
It is.
Good to know. All right. Do you feel like somebody puts thoughts in your mind or withdraw thoughts from your mind?
No.
Fantastic. And then do you smell, see, taste, or touch what others do not see?
No.
Good to know. All right. And then have you tried harming yourself in the past?
No.
Good to know. If you go home, will you harm yourself?
No.
Good to know. And then do you have a plan of harming yourself in the future?
No.
Good to know. All right. Assuming you are in the house and you smell smoke, what will you do?
Call for help.
Fantastic. And then do you feel you have a medical condition and that you need help from us?
Yes.
All right. We are here to support you, okay? A bit about your general health. Any medical condition before this?
No.
Are you on any routine medication, including over the counters?
No.
Any allergies?
No.
You've got any mental health condition before, please?
No.
All right. Any medical condition in your family?
No.
Fantastic. A bit about your social life. Do you smoke?
No.
How about alcohol you take?
No.
Any recreational drug use by chance?
No.
Fantastic. And then how about you've got friends or families around?
No.
All right. We are here to be your friends and support you, okay? Where do you live and who do you live with?
I'm living alone.
All right. Is there anything that bothers you most at this point you would like to ask?
No.
All right. Any question for me?
No.
Thank you for speaking with me. And are you comfortable? I would like to speak with my examiner at this point, please. I've assessed a 33-year-old gentleman that came in feeling low. He's not engaging. He's not keeping eye contact. He's not no thoughts withdrawal, no thought insertion, no hallucination, and then he's got no suicidal intent. He's terminated from work, but he's has insight, and he don't have any suicidal intent at the moment. My assessment is to keep him here in observation area and complete a head-to-toe examination, take sample for biochemistry, microbiology, hematology, toxicology to rule out any organic cause that could be contributing to this. And I'm suspecting she's got a moderate depression that needs to be reviewed by the mental health team once he's medically cleared.
You finished?
I don't know what else to say.
Okay. Thank you. You still have 15 seconds. Anyway, what do you think it is?
It seems I'm missing something, but I can't remember. I just came back from work. I'm stressed.
Okay, you are doing well. So your task here, assess mental state exam. So you will talk to the actor, and in the end, you will present your finding to the examiner in the last minute. Okay. So you follow the general approach. Excellent. Here, accuracy, you almost mentioned all the points. You are very fluent, organized, supportive at all, and safety, you are doing very well. Here, regarding the general approach, part one, you ask all the questions. Uh, you ask him the question of depression mania, impaired cognition questions you ask, psychosis question you ask, self-harm question you ask, judgment you ask, insight you ask. Okay, so this question already you did. Well done. Then the general approach part two you did also. You presented your finding to the examiner, so the patient is well dressed, sitting calm, poor eye contact, low pressure of speech, low tone, low mood, no thoughts disorder, no hallucination, intact cognition, intact insight, intact judgment, but you did not
Yeah,
mention
they are
intact.
not complete. Yes.
Yes, you ask the questions, but you did not
Mhm.
mention that in the presentation. Okay. He has no
Okay.
suicidal ideation, no self-harm ideation. Patient has symptoms of mild depression. It could be because of
Mm.
termination and or separation. Did you mention that? No.
No.
So if you have clear cause for the depression, mention, right?
Yes.
Okay. You did well in the management plan. Okay, well done. Then you should continue the management plan. You said the patient needs a psychiatric assessment under mental health team. Good. Then you can say if the patient refused, what you will do?
Um, capacity assessment.
Excellent. Did you mention that? No. You
No.
should say if the patient refused, I will do mental capacity assessment. And if he has capacity, I will respect his decision.
Yeah.
And it may be safe to be discharged. Easy?
Easy. Yeah.
Done. So I will give you a 9 out of 10. Well done. Thank you.
Thank you, sir.
Well done. Next one, anyone did not practice? You can raise your hands, guys. Sheikha?
Yes, doctor.
Okay. You have 30 seconds and 6 minutes.
Okay, I'll start.
Okay, please.
Okay. Good afternoon. I'm Dr. Sheikha, the registrar. May I know your name and age? Nice to meet you. Then what's your name and age? Okay, nice to meet you. How can I help you today? Okay. Are you in any pain? Are you comfortable? Okay, so do you have any trauma? Can you tell me more about what happened today? Any trauma? Yeah, any prior surgery or medical problem? Okay, so today I'm here to examine your shoulder. This would involve looking, feeling, and some movements. For this examination, you would need to undress your and the t-shirt. Okay, is that okay? Okay, so I'll start by looking. I'll look at both shoulders from the front, back, and sides for any abnormalities. Okay. Then I'll move to palpation. I'll start with I'll only concentrate on the right shoulder for the sake of time. So I start with palpating the sternoclavicular joint, then the clavicle, pressing the clavicle, then I'm pressing the acromioclavicular joint, and looking at the patient for any tenderness, and then I'm pressing the humerus, and I'm pressing the borders of the scapula. Okay. On the borders of the scapula.
And the head of humerus.
And head of humerus. Okay. So the patient has tenderness on palpation of the humerus and the borders of the scapula. Okay. Then I'll move with assessing the active range of motion. So can you put both your arms on the wall?
The patient cannot move the right shoulder.
Okay. So I'm sorry, you're in pain? Do you need any painkiller? Okay, so the patient is unable to do active movement on the right shoulder. So this can be either a fracture or dislocation or an injury to the nerve or muscles or tendon. So I'm gonna assess the passive movement in order to differentiate. Okay, so I'm now assessing the passive movement of the right shoulder.
Active movement, doctor. Continue active movement.
Okay, active movement. He said we cannot move the right shoulder.
This one. I did
Okay,
not
sorry.
say in all directions. This one. You ask him to push the wall.
Yeah.
The patient cannot move the right shoulder.
Okay, sorry. Okay, can you now put both your arms behind
Cannot move the right shoulder.
Okay, can you now put your arms behind the back?
Cannot move the right shoulder.
Okay, can you now raise your arms both up, abduct them? Okay, can you put them back?
Cannot
move them.
Move the right shoulder.
Okay, now can you raise them on your side upward, both of them?
Same, not.
Okay.
Okay,
now can you bring both your shoulders in toward your chest?
No right shoulder.
Okay, and can you now make this movement like me? Do not put your both arms next to your chest and externally rotate them.
Cannot move the right shoulder all direction.
Okay, and now do this movement, internal rotation. Okay, now I'm gonna raise it and feel for the borders of the scapula. Okay, so patient now he cannot do active movement in all directions. So I'm gonna move to. So this can be either a dislocation or fracture or nerve or muscle injury. So I'm gonna do the passive movement in order to differentiate. Okay, now I'm gonna repeat the passive movements by myself.
No, doctor, don't touch me. Don't touch me.
Oh, I'm really sorry. I'll give you painkiller. I'm really sorry. So the patient is refusing passive movement due to pain. So this can be, it goes with fracture or dislocation. Okay, so then I'm gonna move to doing the special tests, starting with a painful arc test. I'm gonna raise the arm up to 180 for the patient and then bring it down slowly. Okay, now I'm bringing down from 180 to 120.
You will do which side?
The right side first.
No, don't touch me, doctor. Don't touch me.
Yeah, okay, I'm really sorry. So, patient is in pain, so I'm unable to do the painful arc test.
I'm not in pain. I don't want to touch me.
Yeah, so he because we're suspecting a fracture or dislocation, so I'm not gonna move the arm for the patient.
So I'm the examiner. How you will do this painful arc test?
I'm gonna we cannot do it because the patient
Yes.
we need to
How to
immobilize
do?
it.
How to do? Show me how to do.
Yes, we're gonna raise it. We're gonna raise the arm up to 180,
Oh, do on the
and then
patient. Do on the patient.
okay, I'm gonna do it on the other side. I'm gonna raise the arm
Okay.
up to 180 passively, and then I'm gonna bring it down slowly, from 180 to 120. If there's any pain, then we are suspecting a acromioclavicular pathology.
Okay.
If between 120 to 60, we think of impingement, supraspinatus impingement,
Okay.
and 60 to 0, we think of supraspinatus tear. If there's a drop, okay? This is how we do it. Then the other special tests are the empty can test, which usually we do it. I can do it on the other arm. We raise the patient arm to 90, and we make his thumb downward, and I'm gonna press stabilize his shoulder and press down, looking at the face of the patient. If there's tenderness, if there's changes in the face, then it suggests that there is supraspinatus impingement. Okay, and if there is a drop, then it goes with a tear, supraspinatus tear. Okay, and then the other special test is resisted external rotation, which usually suggests a problem in inferior in infraspinatus and inferior teres minor, and the lift off test is for subscapularis injury, and also there's the scarf test, which is flexion of the elbow and touching the other shoulder, and we're gonna press toward the other shoulder. If there's pain, then it suggests acromioclavicular pathology. Okay, this is the special test for the shoulder. So I finished the examination for this patient. So the patient has no active movement in all directions, and no also passive movement because of and with the severe tenderness on pressing the humerus and the borders of the scapula, which is suggestive of a fracture in the humerus and the scapula area. So for that, I'm going to immobilize the patient with a sling and complete my examination, and I'm going to do x-rays. Okay, so I can see the x-ray. It suggests that there is an anterior dislocation of the right shoulder. So I'm gonna we're gonna give a painkiller for the patient, and we're gonna do a procedure sedation and a reduction. Okay.
Okay, thank you, Sheikh Shan. Thank you. Okay. Your time finished 1 minute ago. I give you a chance to finish. So here, if the patient cannot do active movement, okay, it means a fracture or dislocation or nerve or muscle, clear? You
Yes.
have you have four muscles, rotator cuff muscles, four. So you can ask the patient, can you do like that? So which is good in communication? You will say, can you do like that? Or you will ask him, can you put your hands behind your head and blah, 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 blah. You are wasting time.
No, I will do it, but I mean because it's a recording, so I cannot do. That's why I'm speaking. I'm
Just
telling the
say,
movement.
can you do like that?
Okay,
In
sure.
online session, we will understand you. In the exam, the examiner will understand you. Clear?
Yeah, sure.
So you will do the same action and ask the patient, can you copy from me? Can you do like that? Thank you. Can you do like that? Thank you. Can you do like that? Thank you. If the patient is not moving his shoulder in this action, in this action. In this action, you can comment in the end for all actions. Did you get my point?
Yeah.
For example, he's not moving right shoulder here, ignore. He's not moving the right shoulder here, ignore. In the end, you can say the patient is not moving the right shoulder in all directions. Do not waste time. Clear?
Yes.
You are wasting time. Okay. Then you
Okay.
can say, I will do painful arc test. The patient already told you, don't touch me. Don't touch me because of pain? No.
No, because
You already gave him painkiller in the start before starting, right? Do you think it's a logic to start the examination and the patient has pain?
no.
You ask the patient in any history or any examination, are you comfortable? Do you have any pain? He said no. Easy.
Yes.
The nurse gave me painkiller. It means the patient has no pain at the moment. So if he asks you, don't touch me, not because of the pain,
Mm.
because mechanical problem, the the fracture or dislocation like this, no pain at the moment. But once you will move the shoulder, it will cause pain. Did you get my point?
Yes.
No pain. But if you will move the shoulder, it will cause pain. The patient feel. The patient is sure once he will move, he will get pain. That's why he is refusing to touch him. Easy.
Yes.
He is refusing to move to himself, active. He is refusing for you to move to him, passive. Some doctors, sorry, in the exam, they are not knowledgeable. They will say, I will give the patient painkiller. Why you will give painkiller? He doesn't have pain. Already, you cannot examine any patient with pain. I wish it's clear.
Yes, it's clear.
You cannot take data from any patient with pain. You cannot examine any patient with pain. You should make the patient comfortable first. I wish it's clear. Okay, so you will give him uh, morphine or any strong painkiller, no problem. This will not mask the pain. Why? The patient has no pain at the moment, but once you will move the fracture or move the dislocation, will cause pain. That's why the patient will refuse. So if the patient refuse touching him, don't force him. Easy?
Yes.
Okay, don't say I will give you painkiller and exam. No, just to say the patient has no active movement and no passive movement, it could be fracture or dislocation. Done. Then don't waste the time. So you can say, I will do complete physical examination, observation room, and do X-ray for the joint. Any joint examination, X-ray. Any station, any station. X-ray, they will show you the X-ray. You can say, I can see anterior shoulder dislocation. What you will do now? Conscious sedation, reduction, minimum 3 staff, reduction, and then repeat X-ray and arm sling. Then refer. If they show you the X-ray after reduction, you can check if the patient has any fracture or anything. If reduced already, you can move to fracture clinic. Easy.
Yes.
If they show you the X-ray after, check any fracture or failed. What if they said this after reduction? What you will do?
Then we can, if failed reduction and there is no fracture, we will involve orthopedic.
Yes, you can say this X-ray after reduction. It means a failed reduction. We will refer for ORIF. Easy.
Yes.
Or at least to say to orthopedic team, maybe you failed from you. Maybe the orthopedic team will be successful in reduction. I wish it's clear. Sometimes the orthopedic team fail to reduce. They will send the patient to surgery, open reduction. Clear?
Yes.
Okay, well done. I will give you 8 out of 10. Thank you.
Thank
Next
you.
one, Aton.
Yes, doctor, I am present, please.
Yes, you have 30 seconds and 6 minutes.
I am ready.
Yes, please.
Good morning. I am Dr. Atul. May I know your name and grade, please? Thank you. I believe you are here for wound infiltration. I believe you are here for regional anesthesia feed block for wound infiltration. Is it correct? Okay. So I will teach you wound infiltration today. So for teaching, I will set some learning objectives. I will tell you how the procedure is done, what is the pre-procedure consideration, any possibility of any complication during the procedure, how to treat the complication, and what is the location, how to perform the exact procedure, and post-procedure care. And I will give you some RCAM websites and study material to read in detail. And in the future, whenever the patient will come, I will show to you. Is it okay for you? Okay. So to start with first we need the what is the area of concern. It is a forearm, yes, uh, and which we will check the site of the injury, and we will first inform the patient, take the consent from the patient, explain the procedure that we need to infiltrate the anesthesia in the wound. So need to ask whether there is any allergy or any bleeding disorder, as these are the contraindication for the wound infiltration, and the medicine used is lidocaine. We are using lidocaine 1% or maybe 2%. The dose of the lidocaine is, are you able to understand, is 3 milligram per kg. And you should know what are the type of complication we have of lidocaine. If the patient develop perioral numbness or uh, uh, abnormal feeling of heart racing, or even up to the cardiac arrest. So the toxicity include of this anesthesia is from mild, moderate, and severe. For mild, it's just numbness and tingling mouth sensation, and moderate, any abnormal heart racing, vomiting, and the most severe is reach up to the cardiac arrest. So we should know what is the antidote. Antidote is lipid emulsion. Okay, so you should know where is the lipid emulsion, and you have all the facilities. Uh, then more important, as you know, this was done for the numbness of the wound, for the wound repair. This is the like the thing. So from 1 centimeter, so what is the instrument? We need needle, we need syringe, and we will insert from 0.5 centimeter to 1 centimeter on the side of the wound. First we will insert the needle and check, withdraw the needle, withdraw the syringe, check whether it should, the this LA, lidocaine should not go to intravascular, so there should not be bleed. Just withdraw the needle and then push slowly uh, along the wound. Okay, from on one side, then do the same procedure on the other side. So this is how to do infiltration. Do you have any question? Are you able to understand? Okay, so after this procedure can be done for the cleaning of wound or wound repair. Is it okay? Do you have any questions? Okay, so after injecting, before starting of procedure, you should check the numbness by just from the forceps touching whether the patient has the local area is numb properly or not. Okay, and this numbness will, remember, this numbness will start after 4 to 5 minutes of
So what
injection.
is the indication, doctor?
Indication for the numbness of the area for the wound, if we need to go for wound repair.
And the contraindication?
Contraindication, any allergy or bleeding or local infection.
Complication?
Complication is maybe local anesthesia toxicity,
Okay.
which I
How
have
to avoid that?
you can give intralipid.
How
You
to
should
avoid that?
to avoid that, use the proper site, proper dose. It should not be more than 3 milligram per kg, according to the age. Okay, per kg, and take proper precautions. And it should go in the skin, in the soft tissue. Please check. It should not go intravascularly when we are injecting. So you should withdraw the needle to check. It should not before injecting. Like while injecting, just withdraw the needle, check whether blood is coming or not. Blood is not coming, then you inject. So take a proper precaution. Or more, you can use ultrasound if the site is difficult. Did you understand? Do you have any question?
Okay, how to do this procedure, doctor? I cannot understand.
Okay. From the wound margin, around 5.5 centimeter to 1 centimeter on the one side, just inject the needle, insert the needle, and it should be parallel to the margin of the wound. And first, with the 5 ml of lidocaine should be in the needle, in the syringe. First, withdraw to check it should not be in the vessel. And if it is not in the vessel, just push and withdraw the needle slowly, slowly, slowly. Okay, and just complete all the area which is parallel to the wound, and then the same procedure please repeat on the other side.
Okay, thank you, doctor.
Thank you. Yes,
Okay,
doctor.
thank you, Atul. Thank you.
Yes.
Okay, so the station, you should follow the same general approach. Okay, so here in this station, nerve block, wound infiltration. So you did well in introduction. You did not ask about the two open questions. So you should say, I believe you have something after introduction. May I know your name and grade? Nice to meet you. I believe you have something to discuss with me regarding nerve block wound infiltration. Then the two open question. How much do you know so far about this topic? You did not ask this question, right?
Yes, sir. Specific, anything specific you
Then
want.
anything specific you want to know? Okay. Maybe the patient, maybe the actor has learning objectives. Maybe he will say, show me how to do the procedure. It means no need to talk about indication, blah, 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 right?
So I forget those. Sorry.
Yes. So the second open question, anything specific you want to know? Then you can set learning objectives if the actor doesn't have learning objectives. I will teach you today indications, contraindication, complication, how to avoid and treat complications, the preparation of the doctor, patient, and equipment, then procedures, technique, steps, post-procedure advice and management, documentation. You should mention all the points before starting. Then go for each point as usual. I think you did well, but you are missing some points. Okay. So
Good.
you should mention how to avoid completely, how to treat completely. The complications should be complete, but you are not complete in all points. So I will give you 8 out of 10. Thank you. Here also the procedure, you should say insert all the needle length, for example, 3 centimeter from the start of the wound till the middle of the wound, the edge, and you can aspirate, no blood, then inject 1 cc, remove the needle 1 centimeter, and do the same. Repeat until you finish all the 3 centimeter. Then you can start from the center of the wound at the edge. Again, insert all the needle lengths. Okay. Then you will aspirate, no blood, inject 1 cc, withdraw the needle 1 centimeter, and repeat the same on the other edge as well. Once you finish, you will get the forceps after 5 minutes. If no pain, you can start the procedure. Okay. Thank you, Atul. I will give you 8 out of 10.
So it is 0.5 centimeter away or 1 centimeter away from the wound. What we need?
0.5,
0.5.
0.5 mm. Okay. Who is happy to do the next station, guys?
I could try.
Okay, this. I think you did this station before,
Yeah, I think I've done it.
so we should ask someone else.
Okay.
Anyone is happy to do this station, guys?
I can do if no one is wanting.
Okay, Sheikha.
Okay. So I'll start.
Okay.
Okay. Good afternoon. I'm Dr. Sheikha Eidi, Registrar. What's your name and the grade? Nice to meet you. Can you tell me more about what happened today? Are you comfortable? Do you have any pain? Okay. Any prior surgeries or trauma? Okay. So today I'm here to examine your hand. This involves a look, feel, and move, and you would need to expose both your hands for this examination. Is that okay? Okay. So I'll start by looking. Can you put both your hands on the pillow, please? I'm looking at the hands for any from the front, from the dorsum and ventral, and the fingers for any abnormality. Okay, so I can see a cut wound on the close to the metacarpopharyngeal joint. Please, nurse, can you put a dressing on it and cover it? Okay. Then I'm gonna move to feeling. I'm gonna start with the palpation, with feeling the bones. First, I'm gonna feel the carpal bones. Then I'm gonna feel the metacarpals and the phalanges for any tenderness. This is the pain is next to the wound, so I'm really sorry. Yeah, I'll give you analgesia. Okay. So the patient has tenderness next to the wound. After I'm gonna feel also for the radial and ulnar pulse, and I'm gonna feel for the capillary fill in both hands. Okay. So then I'm gonna move to moving. Can you make a fist in both hands? Okay. And then can you spread open your digits? Okay. Can you now do this wrist flexion? Can you do this wrist extension? Okay. So the patient has a normal active movement of the wrist and of the wrist and fingers. Okay. Okay. So then I'll move to passive movement. I'll move
The
the finger.
patient has normal middle finger? No.
Okay, so the patient is unable to flex the middle finger actively. So this can be either a fracture or a nerve injury or a tendon or muscle injury. So I will do the passive movement to differentiate which one. Okay, so then I'm gonna move to the passive movement. I'm gonna move passively, close the fingers and then flex them or then open the fingers.
The patient is silent. The patient is letting you to do passive movement.
Okay, so the patient is allowing me to do the passive movement of the middle finger. So it goes, so most likely it is either an injury to the nerve or muscle or tendons. Okay, then I'm gonna check the power. Don't let me push down on the fingers. Okay, both hands. So
Resistance.
okay, so radial nerve is intact in both hands. And then can you spread your fingers and don't let me close the fingers down? Close.
Resistance.
Okay, so the patient has intact ulnar nerve bilaterally. Now, can you raise your thumb up and don't let it be pushed down?
Resistance.
Okay, so the patient has intact also median nerve bilaterally. Okay, then I'm gonna check the function of the hands. Okay, I'm gonna check the sensation. Sorry. So I'm gonna. This is the cotton. Can you feel the cotton in your chest? Okay. Then I'm gonna check the cotton on the dorsum of the thumbs, both area. Do you feel it? Okay. Then so radial nerve, so median nerve sensation is intact bilaterally. Then I'm gonna check on the small finger. Do you feel it? Both sides. Okay, so ulnar nerve sensation is intact bilateral. Then I'm gonna check the middle finger. Do you feel it on both sides? Okay, so the radial nerve sensation is intact. Okay. Then I'm gonna move to the function of the hand. Can you close your hands, both of them, on my finger? Okay. Now can you close using
The
the
patient
thumb?
cannot bend the middle finger right hand.
Okay. Okay, so the patient is unable to bend the middle finger. So can you use your index and the thumb to hold my fingers?
Yes.
Okay. Then can you take the coin with your thumb and index and
Yes.
put it back on the table? Okay. And then I'm gonna check the PIP and the DIP joints. First, don't let me. Can you flex your DIP joint?
The
Okay.
patient can do this test, cannot do this test.
Okay. So the patient is able to flex the PIP, but unable to flex the DIP, distal interphalangeal joint. So, okay, so most likely the problem is with the flexor digitorum profundus tendon.
Superficial.
Yeah, sorry, with the tendon superficialis tendon injury. So I'm gonna I'm gonna give the patient a painkiller already we gave him, and we're gonna give him. We're gonna ask about the injury. Was it a dirty? How did the wound happen? So that we can decide on the tetanus. If he needs tetanus. Okay. So if it's a dirty wound, I'm gonna give the tetanus and antibiotics, and we're gonna do X-rays to rule out any foreign body in the wound, and we're gonna also refer to the hand surgeon.
Okay, thank you, doctor. Okay, well done. So this tendon, flexor digitorum profundus, if you hold the finger from the middle phalanx, and this test for superficialis. Clear?
Yes.
So if he can bend the finger in this test, it means profundus intact. If he can not fix, if he cannot flex, so it's profundus compromise. Here, if he can bend, so superficial is intact. If he cannot bend, superficial is compromised. Clear?
Yes.
Okay. So you should ask about ample history in the start to see if the patient is immunized or not and what happened with the wound. Is it wound in the kitchen, wound in the farm, or anything? So clean or not? Clear?
Yes.
Okay. I will give you 9 out of 10. Thank you.
Thank you.
Well done. Okay, next one. Edis?
Yes, please.
Yes. You have 30 seconds and 6 minutes.
Jesus.
can start.
I'm not comfortable with this patient cognition exam. Dr. Honey, my apologies. I don't know this station. I don't know how to do mini mental state exam. I forgot.
Who is happy to do this station, guys?
I could try. Let me try.
Okay.
Hello, I'm Dr. Edith, one of the emergency doctors. Can you confirm your name and date of birth and age for me, please?
Yeah, I think I'm Ragi, maybe 80 years.
All right. Nice to meet you, Gregory. How may I help you today, please?
I don't know.
All right. I'm here to assess your cognition to see how best we can help you. All right. Have you come in with anyone?
I don't know.
You've got any medical condition before this? All right. Do you take any medication? Groggy, do you know where you are?
Hospital.
Fantastic. Do you know the name of the hospital?
Okay, thank you, Odis. Thank you. Thank you. Okay. Um, I'm not happy with the practice today. Yes, people who practice today, they are doing well, but I'm talking about not all people, they are raising the hand. But people who practiced, you did well, guys. Number one, you are active, you are brave, and this is the most important to pass the exam. Okay. If you are silent and you are watching, this is not good. Anyway, here they ask you to assess cognition only or assess cognition and the mental exam.
Cognition and mental exam.
It means a mental stat exam, right?
Yeah.
Because
Yeah.
cognition is part of mental exam. So you can say, I am here to take some data from you regarding your mental health. Okay. So you should do the station as any station. You did that in previous station for depression. Do you remember?
Yeah.
So you will do the same, but what is the difference? What is the modification? You will ask these questions first, okay?
Yeah.
In detail. So you should say, good morning, blah, blah, blah. May I know your name and age, please? Nice to meet you. How can I help? You have three open questions. How can I help you? I don't know. No worries. We are here to help you and support you. Then can you tell me more about your problem? I don't know. No worries. Okay, I'm here to take some data from you regarding your mental health problem. We'll be in private room, one nurse with us as a chaperone, and you can stop me at any time. Then you can start by the cognition questions. All these questions, yes. Can you tell me we are in which year? Thank you. Season? Thank you. Which month? Thank you. Which day and the time? Is it morning, evening, or night? Thank you. We are in which country? Which county? Which city? He will say, I don't know, I don't know, I don't know, I don't know. So continue. Can you repeat the names of three simple objects? Pen, car, watch. Can you subtract increments of 7 from 100? 5 times. Thank you. Do you remember the same three objects from earlier? I cannot remember. No worries. Can you name two everyday objects? Pen, watch. Excellent. Can you repeat no ifs, ands, or buts? I don't know. No worries. Can you follow three-stage commands written in this paper? Take this paper in your hand, fold it in half, place it on the table. Thank you. Can you read and follow instruction? I'm writing, close your eyes. In the exams, you will not provide paper, just mentioning them like this. Follow the same way. Can you write sentence in this paper? They are not providing paper, but we are acting. Can you write sentence in this paper? Must contain subject and verb. Thank you. Can you copy a drawing which is typically two intersecting pentagons? Thank you. Then you will ask questions of depression, impaired cognition, already finished. So question of depression, you will ask, how is your mood? He will say, I am okay. Thank you. Then, do you feel someone or something interrupt your thoughts? No. Do you hear, see, smell, or taste anything which others cannot? No. Did you try to harm yourself in the past? No. If you will go home, will you try to harm yourself? No. If you smell smoke at home, what will you do? I don't know. Do you feel you have medical problem and you need medical help? I don't know. Then you will jump to medical approach to general approach part 2. Any past medical disease? Yes, I have UTI last month. I'm sorry to hear that. Any mental health problem? Any previous surgery? No. Any prescribed medicine? They said just drink plenty of water. Any allergy? No. Any disease run in your family? No. Whom do you live with and where do you live? I'm living alone. Do you smoke, drink alcohol, or by any chance use any illicit drugs? No. What do you do for a living? I'm retired. Would you like to add anything? No. What is your concern? I don't know. Okay. He said I have tummy pain. Oh, sorry. Do you need painkiller? No, it's okay. Okay, I finished my questions. Are you comfortable? Do you have any pain? Okay, I will present my finding to the examiner. I have assessed Mr. Raghi, 80 years. He has severe impaired cognition and he has minor fall. Maybe this is a reason. He has last month's UTI. Maybe it's recurrent. He has tummy pain. Maybe it's reason of UTI. So his presentation, well dressed, sitting, calm, normal eye contact, low pressure of speech and low tone, normal mood, no thoughts disorder, no hallucination, severe impaired cognition, no insight, no judgment, has no suicidal ideation, no self-harm ideation. Patient has severe symptoms of impaired cognition, so I need to keep the patient in observation room to complete physical examination from head to toe, do some blood tests, including um, inflammatory markers, full blood count, infection screen, and I will do urine test to rule out organic cause. Patient needs psychiatric assessment if organic cause ruled out under mental health team. Cleared, EDAS?
100%. 100%.
Okay.
Thank
So,
you.
welcome. So, the most important, you will do the station like any mental health station, like depression, like mania, like anything. But in questions of cognition, you will ask in detail.
Complete.
Yes, complete. This is the main modification. He will give you all information. I don't know, or I cannot recall, or I cannot subtract.
Yeah.
So time, he doesn't know. 5 points cancelled. Can't place, 5 points cancelled. And the registration, he cannot remember. Subtraction, he cannot subtract. Remember, he cannot recall. So
Yeah.
5 points missed, 5 points missed, 3 points missed, 5 points missed, 3 points missed, 2 points missed. So the score will be less than 10. Okay.
Okay.
Because this one missed. Okay. So this is severe impaired cognition.
Cognition.
Easy?
Easy.
Okay. Um, Next station. Who is happy to do this station, guys?
Can I do, sir?
Okay, Atu. You
Can I
can
start?
start.
Yeah. Good morning. I am Dr. Atul. I am ED registrar. May I know your name and grade, please? Thank you. I believe you have one ECG to discuss with me. Can you tell me how far you know about the ECG? Do you want any specific thing in the ECG? Okay, I will set learning objective. I will tell you regarding the ECG, what are the checks. First, to recognize the identification of ECG by the patient name and speed. And then we will go for chest leads, limb leads, and followed by what is the rate, rhythm, then go for the axis, then go for different intervals and diagnosis of the ECG. Is it okay for you? Are you understanding? Okay. So coming for this ECG, first we need to check this lead 1, 2, 3. These are the limb leads, uh, AVR, AVL, AVF, limb leads, and chest leads are V1 to V6. Okay, so there is a small square and there is a large square. So we should know this small square is 0.02 second, and this large square is 0.2 second. Okay, so uh, and this one to this all the leads are sorry, the lead 2 is for the long lead. Okay, so coming to the this ECG. So how to calculate the first rate? So rate, there is a PQR is there, like in you see the lead 3, there is a P wave. Okay, and this is followed by QRS interval and followed by T wave. T is inverted in this ECG. So P is atrial depolarization, QRS is a ventricular depolarization, and this T wave is ventricular repolarization. Is it okay? So you have to see this is the normal this normal rhythm of the ECG, PQRS. Okay, if it is follows. Now from R to R, you have to calculate the number of large square, and you have to divide 300 divide by the number of large square. Okay, so that will tell you how much beats per minute, heart rate. So in this case, if we go for lead 2, and 1 2 3 4 5 6 7 8 9, around 10 squares are there. So probably 300 divided by 10, 30. So this is a bradycardia ECG. ECG of bradycardia. So heart rate is less than 60 is always bradycardia, more than 100 is tachycardia. Coming to the axis, this you have to see lead first and lead 3. So if the QRS is uh, going down negative in first, and in 3 positive, it is approaching. So this is right axis deviation. If goes away, like if in lead 1 is up and in lead 3 is down QRS, and then it is going away, then left axis deviation. So in this case, right axis deviation. So I completed rate, rhythm, and axis. Okay, so now in this ECG, if you see the lead 2, see P, QRS, and T, then there is again P wave is there, so there is a missing beat. Okay, and again, but means after P, QRS is not there. Then in the another, we have a P and again QRS. Okay, so uh, QRS is not followed by uh, this P. So this is a basically a heart block. Okay, so we need to see which type of heart block. Okay, so this is basically R. This R to R is 30. We check the rate. Now we need to check the this P to P. P to P is 1, 2, 3, 4, 5. Only 5, this large square, so 300 divided by 5. So this is atrioventricular, we know a dissociation. R wave is not P wave is not proportional to the R wave. Okay. Now coming to this, so this is a complete heart block. Okay. So coming with this right axis deviation, and we have to see in such case this uh, in V2, in V3, in V5, V6, we have to see the this PQRS slurred S wave in V6. Like so, there is a three things: right axis deviation, heart block, and this slurred S wave. So it is a trifascicular block. Okay, so it is a complete heart block. We need to this patient, such a patient, we need to put in transcutaneous pacing. Okay, are you able to understand? And we need to first give atropine because this is a bradycardia and complete heart block. Are you able to understand? Anything you want to know?
Okay, thank you, doctor. Thank you. Excellent at all. You are doing well. So in heart rate, you can say atrial rate should equal ventricular rate. Atrial rate 300 divided by large squares between BB, and the ventricular rate 300 divided by large squares between RR. You will find atrial rate is 60 and the ventricular rate is 11. 27. So it's not equal. It's called AV dissociation. What else? HB wave should be followed by QRS. Here, all B waves not followed by QRS. So it means dropped. So this one dropped, 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 dropped. Okay. What else? BR unequal. BR unequal. You should say BR normally 3 to 5 small squares. So here within 5 small squares, here more than 5 small squares, more than 5, more than 5, and unequal. Okay. What else? QRS should be 1 to 3 small squares, 1 to 3 small squares. So here more than 3 small squares. It means white QRS. So this one, we said complete heart block because of AV dissociation, because atrial rate not equal ventricular rate, because of dropped QRS, because unequal BR. What else? Second criteria, we have right axis deviation. Third criteria, right bundle branch block. So complete heart block plus right axis deviation plus right bundle branch block, it means complete trifascicular block. Clear at all? So the management here, you will start by atropine, 0.5 milligram, repeated after 5 minutes, maximum 3 milligram. If failed, give adrenaline 2 to 10 microgram per minute. And if failed, you can give isoprenaline. So adrenaline or isoprenaline, 5 microgram per minute infusion. And if failed, you can jump to transcutaneous pacing. You can consider antidote if there is overdose, glucagon. And here the definitive treatment, transvenous pacing. Okay, you did well. I'm optimizing our approach.
Thank you,
Okay.
doctor.
Yes, thank you. Okay, we will stop here, guys. I was planning to give you the next station. Um, it was COPD vision, but it's almost more than 3 hours and 30 minutes. You are not helping me. Okay, so if you are preparing well, we are active, we will finish within maximum 2 hours and a half. Okay, thank you, guys. And tomorrow, inshallah, will be same time. We will do another mock exam. Thank you, guys. Bye bye.
Thank you, Dr. Honey.
Thank you.
Dr.
Bye
Honey.
bye.